Hi, ladies and gentlemen. Welcome to this edition of the Cameroon Town Hall for Healthcare Professionals. It's been I think, 2 sessions that have been absent. It's quite a big pleasure being here again. And I want to welcome all of you who have taken time to join us yet for another exciting session. Alison and the rest have been doing an amazing job in the past sessions, and it's really great to see that the town hall is always having coverage. We all have different schedules, but we thank God that there is always, an opportunity for you to have the best from the moderators, from the panel of co-moderators that we have. And I want to also continue to thank our chair for the excellent job he's doing to keep this vision alive. We've had really, really many sessions. I can't just even tell you how many we are now on this platform, but I can all tell you that the number is really increasing every day, every session. And we are really, really, really doing our best to make sure that we continue to keep this a regular schedule every fortnight. Today, we are going to be having a very interesting presenter. He's a household name, Dr. Samuel Ojong. So I'm sure everyone is prepared to get the best of presentation today, and we shall be talking about family planning in Cameroon. And before we do that, let's just hear the voices of our amazing presenters. Hello, Alison.
Hi, Elvis. Hi, everyone, and welcome to the 57th edition of the Cameroon Town Hall for Healthcare Professionals. I hope you're well. I hope your loved ones are well. I hope people are keeping warm where it's cold. And for those of you who are up north, I hope you're enjoying the summer. And we're excited because we are having one of us. Dr. Ojong is no stranger to the town hall. And it's particularly interesting because he's going to be talking about a topic which many men usually think concerns only women. So when they talk family planning, the men are like, no, that's a woman's thing. And I'm excited because this topic is one that is going to be covered really well by an expert. Dr. Ojong is the best person truly to handle this. And for men who are either joining us on this platform or watching us online, I would invite you to join the conversation. It's going to be an exciting one. Don't sit back and think family planning is only for the women. Join the conversation. We want to hear your voices. We want to hear your thoughts. Come join us today and discuss and learn. We will be moderating this session with Elvis and Christelle, and I see that Christelle is here with us. Bonsoir, Christelle. Comment ça va aujourd'hui?
Bonsoir, Alison. Bonsoir à tout le monde. Je vais bien. Il pleut un peu à Yaoundé, mais ça va. Bienvenue à chacun à cette nouvelle édition, la 57e édition, tu disais, de Cameroon Town Hall, où nous avons aujourd'hui l'honneur d'accueillir celui qu'on ne présente plus, Dr. Ojong, qu'on connaît très bien dans la Cameroon Town Hall. C'est un honneur, merci. Merci d'accepter d'être là. Et c'est un sujet très intéressant, comme tu disais tantôt, Alison, pas seulement pour les femmes, et pour tout le monde, même les hommes, puisque le planning familial, c'est pas une personne, c'est le couple, c'est 2 personnes. Donc, c'est très intéressant d'avoir des interactions des 2 genres. Merci et on espère que la session sera fructueuse. À toi la parole.
Merci beaucoup, Christelle. So before we begin...
Alison, you can take it. I lost volume. Maybe you can just continue and introduce the rest of the session.
Of course, Elvis. No, thank you. And thank you so much for making the effort to join us while juggling several duties, daddy duties, policy duties, all the different caps that you wear. It's always an honor to have you join us. Before we get Dr. Ojong to present his ideas for today and the topic of today, we would invite our chairman, Dr. Muno Kenefoma, to give us an official word of welcome and to give us any COVID updates that he might have. Hi, Dr. Foma.
Yeah, Alison, thank you. I'm having issues trying to go live. I don't know what's happening.
Okay.
Yeah, but just trying to go live on Facebook. So I would like to welcome everyone, and it's a pleasure always having you here, sacrificing for us to share our Saturdays together. So it's always a pleasure. Today is a very special session. Each time we talk about maternal health, Ojong always comes in with a perspective. He works in the ministry, but I'm not going to start introducing Ojong, but there is always a perspective which is a one which you get from a man who is a gynecologist, but who understands the basics of public health, who understands the pain which women and families go through. So I think today we're all going to share in that pain and see exactly where our country stands and where we're going to in the future. So Alison, let me share my screen, but before sharing my screen, I'll try to go live again. So I've been trying, I don't know what's happening. But okay, it looks like I can go now.
Okay.
So just permit me a minute, let me go live on Facebook. Okay. So now I'm live on Facebook. You can share the link from my Facebook page and then we can. So I will start by just giving a little update on COVID and also on monkeypox. And without wasting much time, because I know this topic is a very hot topic and a lot of people would want to know what is happening. Family planning in Cameroon, when I was growing up as a child, each time I hear about family planning, I was thinking it's more of trying to reduce the number of children that we're having. So I think Ojong is going to tell us today, despite being a physician, there's a lot we don't know, and that's not my specialty. And so today I'm very excited. Ojong is a friend and a brother, and I'm happy that he is always here to come in and fit in and help to enlighten us. So we are living in a strange world. Really, infectious diseases, we're getting a lot of infectious diseases, and things don't seem to be getting better. This is just a cartoon showing you exactly what's happening at the level of the CDC. The CDC had to come out up front. It's something we have been saying for months, that the CDC lost track of controlling the different pandemics, especially being an agency that was sponsoring several other junior agencies in the world. They really failed in this pandemic and they need a revision. So right now you do see here, we are not yet controlling COVID. Monkeypox has stepped in. The MAGA virus has stepped in. Polio is in New York and other places. So we're starting to see a lot of loose control in terms of diseases. So monkeypox actually is an emerging, not a new disease. It's not de novo, but it's re-emerging, and there is a lot of light into trying to get a grip of this. So we have gone through this. We know it's an autopox virus, and this was first discovered in 1958, where researchers were doing research in monkeys. That was in Belgium, and that's where the name came about for monkeypox. Here we can see prior to 2022, these were the countries where you had monkeypox in Africa. There were 2 strains or 2 clades of monkeypox. Out of Africa, there were very few places that had had monkeypox before, including the US, UK, Israel, and Singapore. But most of the places were all in Africa, and it was kind of a neglected disease. So you do have the West African clade and the Central African. The names have been changed to clade A and B and 1 and 2. So we do know that what is circulating now is a strain that developed from the West African type, not the Central African type. And the West African type is less deadly than the Central African type. These are the different modes of transmission for those who don't know. It includes primary infections from animals to humans, and now we're having secondary infections from humans to humans. And we do also know that you can have different forms of manifestations, which I'm going to talk about. So it's you can get it from respiratory droplets, lesions from materials that are having the infection. You can also get it from body fluids and contaminated materials. So we do know that the virus enters through the respiratory tract, the mucous membrane, and breaks skins. This is the most recent data that is available right now. I'm going to go through this data and show you exactly. As of yesterday, there were 46,724 cases. The US is championing with almost 17,000 cases. That's 16,925. If I checked on it this morning, I'm sure it would have clocked 17, followed by Spain, then Germany, then the UK, France. Brazil also has a high number of cases. I think Brazil is almost topping second right now. These are the different states. I'm presently in New York City. We are always championing this thing. So we're the highest when it comes to number of cases. And the CDC is doing a lot. I'm going to leave this here for those who want to know exactly what to do. If you want to do some training in your country, organized training, you can always go to the CDC's website and get to see what to do. Classical cases of monkeypox prior to the pandemic, we had the incubation period being about 5 to 13 days. And then you do have, it ranges from 4 to 17 days. There were prodromic signs, which we are not really seeing those prodromic signs right now, like fever, malaise, headache, weakness. It's more like a sexually transmitted disease right now. You have rash that appears shortly after these prodromic signs that you see them. And typically, the disease lasts for 2 to 4 weeks. So these were the classical symptoms we saw with monkeypox. I'm going to show you what we see now. So in the CDC website, you do have the evolution up to getting to become a scar. One other thing is it's a known scarring mass, but it could still leave a scar as much as smallpox did. So while in the clinical situation in 2022, we do have scattered or local rash that is available, is found. The rashes are usually macular in areas, and they are found mostly around the areas where you have sex. Genital, urinary area, perianal area, and the buccal area. So these are all things those of us people need to be careful about. People present with proctitis, they present with oropharyngitis, laryngitis, and from oral sex. And it's affecting, if you look at this New England paper, it's showing you exactly the areas that are affected, and mostly those who are gay have been affected. That is why it's becoming a stigmatizing disease, up to the point where some kids have had it, and people have not been able to even report that they had it. So you see here, these are the genitals that are affected in certain areas. These are new cases that were reported in Spain. Spain did a good documentation. This is around the perianal areas and the vagina area. Here you see the peribuccal area, where you do have lesions around the mouth and even regions in the pharynx. So transmission is really from person to person. What we are seeing now, there's direct transmission, there's respiratory transmission, touching, and also you could also have through the placenta. Now we need to really be able to examine patients once we see patients coming with rash, collect a brief history, understand their travel history. Travel is no longer really important in most areas where it's endemic. They're actually getting it from each other. Evaluate STDs and their sexual behaviors, because with poor sexual behaviors, those are the same people who get it. There was a new paper that was released in the New England Journal of Medicine, looking at the number of sexual partners and the associated number of sexually transmitted diseases a lot of these patients have. So we do know that a lot of laboratories now in the US do tests for this, and we're trying to scale this out to the rest of the world. So we are aware that there is a vaccine. The problem is the number of vaccine doses that are available. So it's a replicate derivative of the vaccinia. The vaccinia is a vaccine, for those who don't know, that is used for smallpox. There have been different forms of it that have been modified. The Janus vaccine, now we're giving it epidermally in order to increase the number of doses. So this actually have been given a special authorization from both the CDC and the FDA. So there is pre and post-exposure prophylaxis, which really right now the data is very mixed. And there are certain common questions people have. I would share the slides like what I did last time. And treatment consideration for monkeypox, there is treatment, but not everyone needs treatment. We need to know that. So in order to treat patients, you need to have those who have severe infections, and usually people who are HIV positive need treatment, pediatric cases, pregnant women. And if you're in an area and practicing and you get to have cases, you should think about this. So there is tecovirimat. It's not widely available in Africa and other countries just because it's a drug that is used now for emergency use authorization. It's available and it reduces the length and duration of the disease. So it's available in most places. If you don't have it, there's IVIG, and there is also Sitoravir, which is available for monkeypox. Now, going back to COVID, we do know that COVID is not over, but things are getting better in the sense that we're getting herd immunity, but not the kind of herd immunity where people really get sick, but almost half of the world has had or have come in contact with COVID, especially those who are in Europe and in the US. We do have the race of variants, which is still going on. Several variants, we don't know what to do. Should we encourage a variant-specific vaccine, or should we use our local initial vaccines in order to boost people? There is also the mystery behind those who have long COVID, and what is the pathophysiology behind this. Right now, we know the BA.5 is the most available variant mostly everywhere in the world. And we do have development of a vaccine, which is going to be variant specific. This is the state of the pandemic here in the US. I'm not going to lay emphasis on it, but it's important to note that the Biden administration has put in a lot of money in order for us to have a variant specific vaccine by the end of September. And these are the advantages and the disadvantages of what a variant specific vaccine is going to do. This is the first update since 2020, and we do know that these are going to be able to cover for the BA.5 and the BA.4.6, which are now circulating in most parts of the world. And in less than 2 months, they can scale this up and also make it available for third world countries like Cameroon. And also they rely on the technology which they use for the flu in order to update these vaccines in mice without necessarily doing human trials. And that can also be a disadvantage. And the FDA is going to make this available. This is the data in mice really showing you that the variant is actually more, the new vaccine is more potent. And here you can see that despite all the rumors you get, the COVID vaccine is truly very potent in reducing severe disease compared to other vaccines that are available. Here is data showing you what COVID has done. Like countries like the US, it has actually reduced our average life expectancy because you have had a lot of people who have died from COVID. But this is what the vaccine has done. It has actually reduced the number of people who would have died. Now we do have pediatric versions of the vaccine available. This is the data that actually was used for those who are between under 5 and those who are between 5 and 11 in order to make this available for kids. So it's safe. You can go vaccinate your kids. If you want more data, you can go read into it. You can contact me. I'll give you more data. There is also the issue of long COVID. And there is the issue of actually using this technology in order to get more out of it, the nano particles, and also using mRNA vaccines. We see here that there is a lot of clinical trials running in using this for influenza, Zika, HIV, things like rabies, even for malaria, Ebola. So the future is really bright. Every pandemic comes with a curse and a blessing. So here are the different trials for those who are interested. The future will have a lot. Some of them are in phase 1, phase 2, and phase 3. And here you can see that the level of transmissibility is actually increasing. And that's really more reason why we have not had another variant. It may come, but the variant that we have now is so transmissible that another variant may be available, but unable to replace it. So here, after the BA.5, what next? So we still have potentials for variants. Few people are wearing masks. Some people are still not having herd immunity, especially in Africa. We do have lack of global commitment still. Animal reservoirs are there. There are several animals that do have it. There is co-infection, which is going to get to us developing a new variant in the future. Here is the state of the pandemic. Here is the way we are actually surveying the pandemic right now by using sewage surveillance, because testing is no longer done regularly in all areas. I always like to put this because there's been a big debate about masks. Masks do what? There's so many studies now coming out and data supporting masks, but there is so much political influence about wearing masks, but you should wear your mask when you're in crowded areas and areas where you think people are infected. So here is just showing you that there was a time in the pandemic where COVID was actually the highest cause of death in Europe and in the US. So it's important to know that. This is the present state of the disease. Africa is still lacking. There was an interesting study that was published in New England Journal of Medicine showing that those who got the BCG vaccine, that's something we had talked about, I think Kenji and I and many others, those who got the BCG vaccine, 3 doses actually had lower COVID infection, but I'm going to follow up with that paper. It was a phase 1 and phase 2 clinical trial. Here you can see that getting vaccination works. And this shows you just still, even up to now, this is most recent from the CDC, those who are getting boosters, how it's helping. So here is the state of the disease in most parts of the world. In the US, it's now the BA5 and the BA 4.46, which is circulating. So each variant which is more infectious replaces the next one. So you can see from this data, here are the different variants and their different characteristics for those who are interested. And you can see here that we do have a genome tree. Brian is good at this and showing you exactly the relationship between the original Wuhan strain and the present strains that are available. Here is just showing you just on Omicron, the different strains of Omicron that have developed and going forward. So in terms of COVID, are we over? We hope we are not. So we cannot lock ourselves out and really still pretend that we're not going to have COVID around. There is still COVID circulating. I'm in the hospital right now, I still see COVID patients. And in the ER, I can count the number of COVID patients that are in the hospital where I am right now. So it's a finish line that we need to learn to deal with and live with COVID. We need multiple strategies like the Swiss cheese model. We have always spoken about these strategies. And so all of this is things that we need to keep doing. We are at the end of road for masks in several places, but we are not at the end of road for COVID. So looking at the data, you would see here that there's still a number of new cases. I'm not going to go into the number. In Cameroon, they have not updated. And I think so far for the past 2 months, they have not reported any case in Cameroon as per the data. But I don't know if that's the reality. Those who are back home can tell me if they are. I just got from a forum, a doctor told me he had COVID in the north, while here there have been no cases. So I think the reporting is also a problem. So we can see that the technology that we are having right now, just because of COVID, where we were able to develop a vaccine in 1 year and an effective vaccine. So future pandemics, I think this is going to be a surplus. Now we do know that more than 12.5 billion doses of the vaccines have been given out. This is the most vaccinated or tested vaccine in the world. And we know the side effects, they are very few and we can document them. So those who are using that excuse know that 12.5 billion doses have been given. And still, developing countries are the ones which are least vaccinated. There is still a whole vaccine hesitancy going on there. And I think I would like Alison in the future to really get to address this with us here. She's an expert with Professor Wisong here. So here you can see that even Africa got the worst of the vaccines. Among the vaccines, there were some which were better than others. And right now, even the ones we got, we didn't use them. They all got expired because there was vaccine hesitancy. And there is development of a pan vaccine in Walter Reed and other institutions in Europe. So here you can see exactly the efficacy of 3 doses. I'm just going to go fast with this. This is just showing you the timeline. And are we done with vaccines? No, we are not. Are we done with variants? We are not. So the next after Omicron is pi. The problem is when, not if it's going to come. The problem is really when. Is the world going to lock itself up? Will Africa be prepared to store these vaccines? Have we learned anything generally from this? And I think we have not learned much. Just looking at monkeypox, even the US has not learned much from this. So in terms of treatment, nothing has really changed in terms of treatment. I'm just going to go through this in 1 minute. Corticosteroids are still the cornerstone for treatment for those who have severe disease. In cases where you have real disease that they do need advanced respiratory equipment, you do have tocilizumab, which is an interleukin-6 inhibitors. You also have a JAK2 inhibitor like baricitinib. This is available in Cameroon and other African countries. Then you have your Paxlovid, which can be given in order to prevent severe disease. This works especially those who are above 65. There was a data that was just released that showed that those who are less than 65 who have been vaccinated may not need it. So here you see the level of efficacy and the mechanism of action. I'll share my slides for those who want to have it. And it's important for us to know that there are other things that do not really work. So remdesivir does work also to reduce severe disease, but it doesn't really work to cure severe disease. So you do have monoclonal antibodies. There are several of them. There is the Evershell. We use this in oncology a lot. In cancer center, we do use this for our patients who have multiple myeloma, our patients who have diffuse large B-cell lymphoma, and those who have B-cell diseases. In order to prevent them, they cannot get effective build an immune system from getting the vaccine because their B cells are very low. So we do use those things that you should not do. Ivermectin should not. Convalescent plasma, no. Hydroxychloroquine, no. Antiretrovirus, HIV medications, no. So we do know that some things work, others do not work, and we have data right now. We are no longer living in the world where there is nothing. Another study came back for colchicine, which was negative, and fluoxamine was negative also. I just saw that recently. So here is showing you that even the president of the United States can get infected, and if not careful, could die. So we should be very careful. No one is invincible. And please, I would give it over to Alison to introduce Ojong, and then we move on. Thank you. Let me stop sharing my screen.
Thank you so much, Dr. Foma, for these highlights. We always come to the town hall knowing that we're going to get our updates on COVID and other ongoing pandemics or epidemics of importance to the wider Cameroon public. Dr. Ojong sent us a few questions. He says we should let you all know that these questions are not meant to make anybody feel bad if they don't know the answers, and that's like the essence of this presentation. And he encourages us all to try to respond to them. Our answers are anonymous, so if you are on this platform and you are someone who is supposed to know these answers, maybe because you work in family planning or you have extensive experience in this area and you don't get the right answers, please do not feel bad. Dr. Ojong is not going to know your answers. This is really just to keep everybody engaged. And we are going to launch the polls right now. So the first question from Dr. Ojong is, the proportion of married Cameroonian women 15 to 19 years old who use any family planning method is. So we'll just give about a minute, and we encourage all participants to please just respond. Don't worry about whether you get it right or wrong. It's just to gauge the level of knowledge on the topic before Dr. Ojong's session. So we are just 3 more seconds away. Okay, so I'm going to end the poll for the first question and share the results. So most of us think that about 19% of married Cameroonian women use any family planning method in Cameroon. So in a bit, Dr. Ojong is going to give us the statistics. So we have to all keep our ears open just to see how well we performed. So our second question for today, the use of modern methods in Cameroon is much higher amongst which group of people? Non-sexually active adolescents, married women, sexually active non-married women, and non-married women. Okay, so we're going to end the poll, and Dr. Ojong is just sharing the responses with me, so I will share them with you in a bit. So most of us think that sexually active non-married women are the ones who use modern methods of contraception. So about 70% of us think so, and we're actually correct. So Dr. Ojong says the answer is C, and he's going to enlighten us a little bit more in a bit about what he means when he says modern methods of contraception. So the third question, the unmet need for family planning is 23%, 33%, 43%, and 53%. So by unmet need, I guess it means like for those who would want a family planning method but do not have access to it. So we have 53% leading, and I'm just going to end the poll in a bit, 7 more seconds. Okay, so the right answer here, I'm just going to end the poll and then share the results. So 66% of us think that 53% of women have an unmet need for family planning. And I'm just looking at what the definition of unmet need for family planning by the WHO means, and Dr. Ojong definitely would share more light on it. It means the women with unmet needs are those who are fecund and sexually active, but are not using any method of contraception. And I think as we listen to Dr. Ojong's presentation, we'll get to hear more about what's happening in our context. The last question, exposure to family planning messages is highest amongst what group of people? Men at 42%, women at 30%, men at 30%, and women at 42%. Ten more seconds. The majority of people, so 45% of us, think that it's highest among women at 30%. Dr. Ojong actually says that the right answer is A, so men at 42%. So I don't know if you all are as excited as I am to hear what Dr. Ojong has for us. So at this point, I'm going to end the polls, and then I'll hand it over to Christelle to introduce Dr. Ojong. Thank you.
Thank you, Alison. Thank you all. I have the pleasure to introduce Dr. Ojong. He's a great man. He's very known in the Cameroon town hall. Dr. Ojong is a passionate obstetrician gynecologist with strong interest in promoting women's reproductive health rights and needs, while advocating for equitable access to healthcare for women and adolescents. So he believes Africa can go ahead by stopping and limiting cliches, and also pursuing research in maternal health. He graduated from the Faculty of Medicine in Yaoundé, and later on went on to specialize in obstetric and gynecologist. After specialization, he went back to school as a Chevening scholar at the London School of Tropical Medicine and Hygiene, where he obtained a master's degree in reproductive and sexual health research. When he came back some months ago, he was appointed at the Ministry of Public Health of Cameroon as the focal point for family planning, where he's currently leading activities. And I'm sure the experience he will share with us today is from what he has observed so far at the ministry, and also his activities on the field. So far, he has been accumulating several positions. I will not go through each of them, from the director of the Fundong Hospital to the ministry. He has a lot of experience to share with us, and we are very happy to have him today. I'll stop there and let's listen to the experts and have more time to discuss about what are the gaps so far, and also what is the progress and what can we do each one to improve our healthcare. Welcome, Dr. Ojong. We are proud of you and thank you for accepting our invitation. Over to you.
Thank you, Christelle. Thanks to Muno and Alison and the entire town hall team. Thanks to everyone who is with us on board. I must confess, when you were presenting, whoever you were presenting, I had to turn around to find out who it is you were presenting. I don't think I was the one. Anyway, thanks for the roses. I will begin by sharing my screen, if that is permitted. Share. Meanwhile, I was really like laughing out my lungs while Alison was sharing the teaser, the testing teasers. And I chose those questions intentionally. I just threw in those numbers there because basically I was trying to say, at the end of the day, what use really is the numbers. Do we really need to come on the town hall to master those numbers and take them home saying, okay, the unmet need in Cameroon is this and this is this? How does it help the person on the front line of the COVID floor, for example? Just statistics, right? Secondly, I told myself, Samuel, I don't need to come on the town hall to have a clinical oversight of family planning, because it's in every book. You have it on Google, it's available through healthcare providers all over Cameroon. And while we'll be open to answering any questions with other really frontline people in family planning, I've seen about 2 or 3 in the hall who are much bigger than me in the family planning game. We will be open to answering questions. I told myself the aim of my overall intention was to make a case for family planning. So I'm not coming from an operational viewpoint, neither am I coming from a public health stance today, but I'm coming in more from an advocacy angle and hoping that at the end of the day, I don't disappoint in terms of your expectations when you're coming to hear about family planning. That said, we will, after I introduce my topic briefly, I will talk about the wins for family planning in Cameroon, talk about the gaps, identify a few opportunities, following which we will conclude and be open to receiving any questions anyone might have. So, like I said earlier on, the overall objective of my presentation today is to make a case for family planning programmatic strength in Cameroon. And in trying to make this case, I'll be adopting a health system analysis of what, in my opinion, is the ongoing family planning strategy in the country. So we begin by saying that in middle income countries, knowing that Cameroon is in that bracket, about 218 million women have an unmet need for family planning yearly. And that translates into 111 million unintended pregnancies yearly, 35 million unsafe abortions, as well as 30 million unplanned births. It is also known that if we were to meet every need for contraception or for family planning in low and middle income countries, then we will have decreased unsafe abortions by 72%. We'll be able to decrease unplanned births by 71%, reduce unintended pregnancies by 68%, and above all, ultimately lead to a drop in maternal mortality by 62%. For those who love the figures, that would be something like 113,000 deaths averted just by making sure that every woman who needs family planning or who wants contraception in low and middle income countries actually has a method provided to her. In Cameroon, however, it's good to state from the very front that sexual and reproductive health and rights are really at the center of policy considerations. Now, going forward, we may argue or not agree as to how effective these policy considerations are beyond just writing, but it goes without saying that from the Maputo Protocol to PARMA, through the ICPD conferences, the MDGs, the Global Strategy for Women and Children's Health, the Global Plan for the Elimination of Infections Among Children and Keeping Mothers Alive, as well as the SDGs, Cameroon has always been at the forefront of supporting international or global policy statements that protect the sexual and reproductive health and rights of pregnant. Talking specifically about family planning, it is actually the second out of 8 priority reproductive health components. And in trying to prioritize this, in her reproductive, maternal, neonatal, and infant health strategic plan, Cameroon between 2014 and 2020 had aimed to develop and implement an integrative strategy for the prevention of mother-to-child transmission of HIV, emergency obstetric and neonatal care, as well as family planning. So we provide this in one-stop shop fashion. Also, she intended to train and capacitate human resources in family planning techniques and especially long-acting reversible contraceptive methods, ensure contraceptive commodity security at all levels in the country, improve on infrastructure and equipment necessary for family planning services, invest in behavioral change communication strategy with particular attention to a schools-based approach as well as community-based approaches for education and communication. She also intended to harmonize costs for family planning services nationwide as a means to improving financial access to these services. And finally, she committed herself to increasing national family planning budgetary spending. However, what I've shown you now is strategic plans, it's saying, yes, it's there in the policy discussion, is agreeing that Cameroon is among the signatories for international protocols and conventions. He's saying, yes, there are implementation plans which have at the center of their considerations improving access and providing family planning services. However, beyond all of this, what is concretely going on in Cameroon as far as family planning or access to contraception is concerned? Let's begin with our wins. And very last non-negotiable win as family planning in Cameroon is concerned is that it's on the policy agenda. I always revel in this statement that says science might find all the evidence, but only politics treats the patient. So the moment family planning became a priority on the policy agenda, it was a big win for all of us, especially those who are in that family planning community. And from over the years, from the reproductive, maternal, neonatal, and infant health strategic plan to the operational plan for family planning, we have seen that many policy documents, many policy statements have been made which seek to really improve on the whole programmatic view on service provision, on access. And most recently, between 2012 and 2020, Cameroon actually made FP 2020 commitments. And we'll be seeing what FP 2020 or now recently, what FP 2030 is all about as we move on. And after the expiry of the FP 2020 commitments in 2020, Cameroon has already currently signed or promulgated her FP 2030 commitments, which will be launched imminently. It's a way of saying that family planning is really high up on the policy agenda, and that is a big thing. If we look back at some of the commitments Cameroon made regarding family planning through the FP 2020 lens, we had strong policy and political commitments, with the government of Cameroon committing to mobilizing a budgetary line for the purchase of contraceptives and committing to subsidize family planning services for the most vulnerable users. Now, when we talk about vulnerable groups, you know who these are. From women, adolescents, uneducated women, unemployed women, the most hard to reach communities, refugee women, with persons with living with HIV and AIDS. So it's about making sure it's like it's a political commitment to say we will fight for equity as far as family planning. Also, the state of Cameroon made some financial commitments. Specifically, she committed to advocate to increase the state's budgetary allocation as far as reproductive health and specifically family planning was concerned. And that commitment was to see to it that she increased this allocation by 5% by the year 2020, and also trying to mobilize donors. Now, 2 years past 2020, how much of this commitment has actually seen the light of day? Also, in line with her EP 2020 commitments, there were those relating to program and service delivery. And specifically, the government of Cameroon wanted to ensure contraceptive security so as to avoid stockouts while providing the full range of contraceptives, and not just contraceptives, but quality services. And above all, she committed herself to ensure that both she and her partners were accountable when it came to funding family planning and its services. Beyond political commitments, we actually have what I'll call public health evidence of some wins. Like the indicators have evolved. We may not agree on how much of a win or how much evolution we would have wanted, but it is clear that from when Cameroon made her FP 2020 commitments, we have seen a rise in the number of women who actually are using modern contraception. So by modern contraception, we are making reference to pills, we're making reference to injectable methods of contraception, to implants, to barrier methods such as condoms, both male and female. So basically everything that requires the use of pharmacology, okay? And we see that between 2012 and 2021, we had that number move, or that number of women using modern contraception from just over 820,000 to about 1,114,000 women. Now that was remarkable. Equally, it's good to note the remarkable rise in couple years of protection, which has occurred within this window. So we can say that significantly, we've been able to have on board more and more women using modern contraception. Of course, if we had to go into a comparative game with other countries, then we may have other things to say, but this is a win. Another win we could make reference to, still regarding modern contraceptive use and the need, is to see how much our modern contraceptive prevalence here in blue has improved. I wouldn't say it's a steep improvement, but we've had close to a 2.6, 2.8% rise in modern contraception, in modern contraceptive prevalence over this period. And what is most interesting on this slide is to see the remarkable rise in the med need from just about 40% to close to 49%. So it has been remarkable in how much more and more women have had their needs met as far as contraception is concerned. Now, if we had to talk about the unmet need, and this was very surprising, yes, unmet need has dropped. However, it remains that the unmet need is more amongst married women than among single women. So I just throw the question, do you think in Cameroon, marriage is a barrier to a woman being able to access modern contraception? That's just one for the books. What about the impact of modern contraception? We have had a good number of unintended pregnancies averted. So from about 300,000 at the start of the family planning cycle or program, it's now about close to 390,000, 395,000 unwanted pregnancies that have been averted just by applying the policies that have been applied between 2012 and 2020. In the same time, we have had close to 130,000 unsafe abortions that have been averted just by making sure that women have access to modern contraception. And I wouldn't talk about the impact without mentioning the impact on death prevention. We know family planning has multiple advantages, and we may comment them in the course of this presentation. But we realize that between 2012 and 2021, that's upwards of 1,800 maternal deaths that have been averted just by making sure that women have access to modern contraception. However, if we were to talk only about the wins, then it wouldn't be a complete presentation, because surely there are gaps. And in trying to look at our gaps, we will use a health system building blocks approach to see how the gaps in each of the health system building blocks overall contributes to the gaps we're seeing as far as family planning programming in Cameroon is concerned. So we'll be looking at leadership and governance, human resources, medicines and technologies, financing, information, and finally, service delivery. I tend to say that leadership and governance is our Achilles heel as far as the family planning program in Cameroon is concerned. And I'm the first to lift up my hand and say guilty, because due to no fault of mine, but I'm not complaining, I'm the family planning focal point for Cameroon. And so it is my role to counsel policy, or to make a case for family planning, or to make sure that policy actually puts family planning on the forefront of its interest. However, like I said, our Achilles tendon is that there is really no programmatic vision or coordination. Now, this may not sit well with many people, and I'm willing to be corrected, but this is what I think we need to start doing if we will move family planning forwards. Because you will hear words like the family planning working group, but who really is a member of the family planning working group? What is really their roadmap? What's their role? Who intervenes? Which service houses family planning? Which team is in charge of family planning? Who is really financing? Who is really coordinating service delivery? What about purchasing? What about logistics? Who's in charge of that? Who is in charge of supervising, and at what levels? Basically, who is doing what? There is a big problem with being able to know exactly who is doing what within the family planning ecosystem in Cameroon. Another area where we may find a gap is financing. And talking about financing, it's good to state upfront that the state contributes just about 1% to all family planning related expenses. And that will be about 1.1% if you had to look at reproductive health as a whole and say how much of the Ministry of Health's budget went into reproductive health. We'll be talking about 1.1%, and family planning is just one aspect of reproductive health. That means that the bulk of our funding when it comes to reproductive health, but also especially family planning, comes from partners. We have multilateral partners, amongst which the UNFPA, without any publicity, is really at the top of the food chain. We also have bilateral support from countries like Germany, US, and other independent bodies. And it's maybe an opportunity to express gratitude to partners who support the state. However, I'll be unfair if I don't also state that the fact that our reproductive health agenda, and especially family planning, is basically funded from outside has actually had to distort national priorities on many fronts. And I always use the example of performance-based financing. Now, we all know performance-based financing is a World Bank initiative, and it's going to roll out by December of this year. But the reality on the field shows that in trying to implement performance-based financing and strengthen hospitals and their pharmacies and granting them the autonomy to purchase from almost anywhere they wanted to. The net effect was that it really messed up the whole logistic chain when it came to family planning or reproductive health commodities. So this led to massive stock outs in some areas, massive expiries in other areas. So sometimes when funding comes from out, as good as it is, we must make sure it's not distorting priorities. Another gap which we must mention is the workforce. Now, the state is the main employer of the family planning workforce in Cameroon. And she's doing a lot. There's a lot of sustained efforts in trying to train more and more family planning providers. However, we cannot say enough that there is not enough chairs for the provider. Now, what do I mean by that? You have the UNFPA, which says that a successful family planning program is one that has a cupboard full of methods, a chair for the provider, and a woman willing to take up a method. Now we have a significant gap in terms of numbers. We have a significant gap in terms of skills. So we have providers who may provide some methods, but are not capacitated to provide others, such as placing an implant or placing an IUD. We have staff who tend to be undermotivated. And the net effect is either they do not focus on providing family planning services, or when they do, they impose costs which could be discouraging to the end user. Surprisingly, some regions are prioritized over others. So now I wouldn't go into specific organizations and their specific priorities, but just to say, in trying to fund, there is this mechanism which permits organizations to say, okay, we will fund in this region because these are the priority regions. But when I look at the statistics, I don't think there is any one region we can say in Cameroon is having green indicators when it comes to reproductive health or family planning per se. So I think that prioritizing some regions is actually distorting the priorities, not to talk of inequitable geographical distribution of these workers. And I will also say, I personally have a critique against the current methods of training, which tend to be offsite. So we bring the healthcare providers and train them during workshops. And because of that, we cannot train huge numbers. It becomes very costly to train huge numbers. And moving forward, I'm hoping to make recommendations towards seeing that we actually capacitate health workers on site within their districts, within their health facilities. And in that way, we can train many more people cost effectively. Service delivery is another area where we could identify some gaps. We have about 4,100 registered health facilities, and less than half of that number actually offer a full or comprehensive contraceptive mix. So as of 2018, only 71.3% of our health facilities were offering short-acting methods, 19.4% were offering the implant, 18.8% for the IUD, and only 4.5% the permanent methods. Now, but for permanent methods, it's good to state that family planning is considered to exist within the minimum package of health. So it should be really delivered at the most primary and elementary levels of healthcare in order to improve access. And also, when we look at that primary level, so the district level of care, we realize that only 63% of our primary level health facilities are able to provide at least 3 modern methods of contraception. So it poses a huge problem when it comes to quality. However, again, we will not mention the fact that there's a lot of technical support that is going on to ensure that service delivery improves from the state's partners. And I am particularly laudable of Cameroon and ACMS, who have a social franchising model. Now, there's lots we can say about as critique with the way the model is run in Cameroon, but nonetheless, we are grateful that they are there plugging in the spaces to ensure that more and more women have access to services. Next, let's look at commodities and drugs. I'm one person who believes that Cameroon has a cupboard full of methods. We do not lack commodities, we do not lack drugs, we do not lack family planning entrants, simply because partners are really, really plugging in that space to ensure that we do not run short. However, a commodity has no use if it doesn't end in the end user's hands right at the last kilometer or at the last mile, okay? If commodities come to Cameroon and end at the ports, or they end at the warehouses and cannot go to those who need them, then they're as good as not having commodities. However, we have huge gaps, I think, with respect to logistics. Again, like I mentioned previously, the whole performance-based financing initiative we embarked on, it really messed up reproductive health logistic chains in Cameroon. And currently a lot is being done in the background to correct that. Also, we need to be able to quantify our needs better and to be really scientific and evidence-based in trying to quantify our needs, without which we end up placing orders for more commodities than we really need. And the end result, which is very annoying, is that we have huge expiries. So a funny finding when it comes to commodities is that you go to some regions and they have been stocked out for quite a bit, and you go to some other region and there's huge stocks that are getting expired. I don't think that tells well as far as we are concerned. And again, I'm one of those to take responsibility. I think we need to have more efficient logistics. Another spot on our Achilles heel is our health information system. We currently use the DHIS2, which is the District Health Information System, to report facility-based happenings, clinical happenings. And family planning is one of those interventions that are captured within the DHIS2. However, compared to other programs, we could think about malaria, we could think about HIV, we could even look at maternal mortality or neonatal mortality, where there is increasing greater policy attention, greater financing and funding, or more developed surveillance systems. When it comes to family planning, we may have a hard time getting real-time data or accurate data from the DHIS2. And again, we have huge problems in terms of surveillance, monitoring, and evaluation, impact evaluation, which should be really ongoing processes. And it brings me to ask a question, which is, are family planning policies evidence-informed or partner-determined? I'm one person who says that policy is not obliged to follow the evidence. The evidence, or those who produce evidence, are obliged to make sure that they translate this evidence to those who make policy. And right now, I don't think we are generating enough evidence. And what better place than the town hall to say we need all these public health competencies, clinical competencies. We need all your experience to make sure that we generate the right type of evidence with regards to family planning in Cameroon that can enable us make actually evidence-informed decisions. And I always talk about the need for a data hub within the Department of Family Health where I work. No data, no real decisions. Let's talk about some of the other gaps. And now I'll ask the question, are women really willing to take up the method? When we look at the use of modern methods by region, we see huge disparities, where we see that, say, 28% of married women aged 15 to 49 are currently using a method in the East, while for that same indicator, only 7% of women are using of these women are using a modern method in the far north. What explains these disparities? Is it that in the far north, women are not willing to take up a method? Or if we look at the demand satisfied for family planning by region, again, I take the East, 50% of the demand is satisfied. For only 17% in Adamawa, is it, now this is not a problem of women, now women want to take up a method. What is the reason why in the East, we have 50% of women who are satisfied? In Yaoundé, we have 51% of women who are satisfied, or say 42% in the central region. And in Adamawa, only 17% of women have their needs satisfied. There are many reasons we could plug in there. But like I've said, we can see regional inequities. And data reveals that some of the reasons some of the line along which these disparities exist is educational level. So we have, for example, only 3% of uneducated women use modern contraception, as against 26% of educated women. We have only 30% of women who have access to family planning messaging. And yes, more men have access to family planning messaging in Cameroon than women, which is 42%. So the question is, how comes they who need it the most or have least access to messaging? And of course, let's not talk about adolescents. They are really one of those groups whose needs we are not currently meeting as we should. We all know that high-quality family planning services must ensure voluntariness, no coercion. Women must be willing to take up the methods. It must not be indicator-based, because sometimes, and we saw that with performance-based financing, because you get paid to provide services and you're paid based on indicators, so you could lead or coerce a woman into accepting a long-acting reversible contraceptive method because it's paid more, even if she wanted, say, to have pills. Or you could coerce a woman into permanent contraception, into non-reversible method because paid higher, even if she would have wanted, say, an implant. And so it must really be voluntary. Additionally, it should be affordable, acceptable, accessible. It should be rights-based and place the interests of the woman, of the person, at the center of service provision. So the question is, are women really willing to take up a method? Maybe, but there are huge barriers in there. One of the very first is we really are lacking a real family planning communication strategy. There's an example I always give. I always say, sit in front of your TV at the high peak hours. From Monday to Friday, that should be between 7 p.m. and say 10 p.m. Weekends, say between 10 a.m. and 6 p.m. You wouldn't see on any of our national TVs one single message on family planning. Go to our main city centers, go to the billboards, listen to our most followed radio programs, you wouldn't get one message on family planning. We are lacking a family planning communication strategy. Additionally, there is lots of stigma still existing in many communities, especially for single women, because of the understanding that if you're single, then you have no business with sex. But what's the reality? The reality is people have a right to their sexual choices. And if a woman or a person is sexually active and doesn't want to procreate, then they have a right to access family planning. There's a lot of religious hesitancy also. We have a huge Christian community, a huge Catholic community, and we know they do not encourage modern methods of contraception. We've already addressed inequities, which could be geographical, it could be socioeconomic. There are also huge gender issues. We're seeing a while back, unmet need seems to be higher amongst married women compared to single women. And there is the ongoing ethical debate in Cameroon. Would you provide family planning to a woman if you knew her husband was against? And I know many a health worker who will say, if your husband is against, I don't want to go to court, I don't have problems, so I'm not going to provide a family planning method. So we have all these gender issues, or women don't have the same economic potential like men, generally speaking. And there's a cost, there is a cost to access some of these services. So there are ethical, legal gaps, sociocultural barriers like we have mentioned earlier. But all in all, these things are plaguing women's rights or their ability to access modern contraception. However, it's not all negative. There is a way forward. And personally, when I look at the indicators, I look at everything that is going on, I only see a host of opportunities, but it's opportunities we must seize right now to make sure that come 2030, when we are looking at the fallout of EP 2030, we are not saying the same things we are saying today. So the first thing I know many people want to ask me is, but why family planning? Why do you even make a case for family planning in the first place? Family planning is one of those interventions with unlimited number of benefits. both health and non-health benefits. So when it comes to health benefits, we know that it reduces maternal mortality in many aspects. You know, it reduces the number of unintended pregnancies, reduces the number of unsafe abortions. It also has lots of child and newborn health benefits, because a woman who plans her pregnancies has more time to accord to her children, to raise her children properly. And then if her body heals properly, then her next pregnancy is much healthier, and neonatal outcome is usually better. It has a lot of adolescent health benefits. This is another area where we have some challenges, because when you talk about adolescents and family planning in Cameroon, then you tend to hit a number of rocks sometimes, because people think you are encouraging loose sexuality. No, the statistics are there for all to see. The average age of first coitus for a Cameroonian girl is 16 to 17 years. It is about a year more for boys. And I'll tell them, if you cannot abstain, you can as well practice safe sex. So beyond health benefits, we know that family planning is a human right. In fact, sexual and reproductive health is a human right for all. We know that there are huge economic benefits. We talk of the demographic dividend, which I'll comment on very briefly as we move ahead. It also plays a great role in environmental sustainability if properly applied. Family planning empowers women, and we know women are the center of community development, community progress. So by empowering women, we actually empower communities. So that's why we need to make a case for family planning, especially in low and middle income settings such as ours. So what are the opportunities? The first opportunity family planning provides us is that, once again, through FP 2030, Cameroon has an opportunity to exist within the global policy space by joining her voice to that of the international community through the FP 2030 commitment initiatives. And this initiative, which succeeds the previous FP 2020, is actually voluntary, actually promotes voluntary, person-centered and rights-based approaches to family planning, with equity at the center of choices. So it's about making sure that all vulnerable groups have access to modern contraception. Also, it ensures that countries make a commitment to gender equality, with support for the empowerment of women and girls, and for the participation of men, boys, and communities within the family planning space. Cameroon will be launching her commitments, and it is my voice, my wish, and I hope yours too, that beyond just written commitments, we will henceforth see visible evidence on the ground that family planning is a priority through the actions we carry out. Family planning provides a huge opportunity in terms of demographic dividend. So for those who don't know, that's put simply, demographic dividend is simply saying, how do we make use of our population structure to pull out the best of economic benefits? Now in Cameroon, we know that those who are aged below 15 make up about 43% of our total population. And for those aged between 15 and 34, that would be a further 36% of the total population. For the young population, there is a strong potential for economic growth. But for us to reap the benefits of this potential, we absolutely need to invest in high impact interventions, which, for one, decrease the fertility rates among this population, amongst which we have family planning. Because basically, we're saying that a 16-year-old, a 17-year-old who is pregnant cannot be working. So we need to empower young people to only get pregnant when they want to. So give them the power to control their own fertility potential. Also, we need to decrease mortality rates, decrease the rate at which children below 5 are dying, decrease the rate at which young people are dying. And just for the books, when we talk about maternal mortality, about 3 to 5% of the women who die in childbirth or in pregnancy are adolescents. These are people with all the potential to contribute economically to Cameroon, whom we need to protect from these preventable deaths. And also, we need to invest in youth capacity building and empowerment. And we cannot talk about capacitating youth or young people without empowering them when it comes to their sexual and reproductive health and rights. all that we have seen it presents to Cameroon is that of finally saying, you know what, we need a total market approach. And like you can see there, there's all these different actors who are involved in the family planning ecosystem in Cameroon, who right now are really like stepping on each other's toes. But they need to sit together and say, who does what within this space in Cameroon, and make sure that we accompany each other in fulfilling our duties. So with the total market approach, we can ensure efficient collaboration and coordination amongst the different sectors, government, NGOs, commercial sectors, build sustainable public-private partnerships around family planning, but also provide a framework for a constructive working partnership between different sectors. If we can do this, then we can also cover lots of things previously and really significantly reduce the amount of waste we are experiencing within the ecosystem. Of course, family planning provides an opportunity for sustainable partnerships because we need to promote the universal access to social and reproductive health and rights for all, including family planning. Family planning, if a real family planning program engages us to invest in innovative gender targeting health initiatives, to invest in policies that address inequities. There is no reason, just by virtue of where I live, I should be disfavored when it comes to accessing essential services like family planning. Sustainable partnership to make a business case. There is evidence that shows that for every $1 spent in family planning in Cameroon, we end up saving $1.23 in maternal and newborn care. Also, if we meet half of the unmet need, just half of the unmet need in Cameroon a year, then we'll be able to save 1.3 billion francs CFA. Now, this is money which could be sent into other sectors to build the country. Finally, when we talk about sustainable partnerships, we know that family planning can contribute hugely to social, economic, and environmental sustainability. But this is something which is only possible if we work together as a country with our partners and with other private initiatives. Family planning provides this opportunity for innovative financing. It's going to be costly. We talk about needing about $25.5 million to address just half of the unmet need. But remember what we said, for every $1 spent in family planning, there is a potential to save $1.23. And it will take us about 18.7 billion to address every need. How do we raise these funds in a setting where resources are scarce and priorities are multiple? We need to make a business case like I'm making now to say, there are sure returns on investment for family planning, as well as quality sexual and reproductive health services if they're properly done. We also need to adopt innovative schemes such as that the UNEP is currently proposing. So for those who are interested, you could always try to look up the Compact initiative, which is actually an innovative method of financing, and especially innovative in the sense that it's calling on governments to take increasing responsibility to be increasingly more accountable for funds they receive for family planning, and also to contribute within the limits of their capacity, their fair share, to the family planning needs of their countries. And at country level, of course, we must find innovative ways to finance universal health coverage in a bid to improve access for everyone, everywhere. I will not end until I share this from a favorite of mine, Mahmoud Fatala, who headed the reproductive health program at WHO at some time. And he said, women are not dying because of diseases we can't treat. They are dying because societies have yet to make the decision that their lives are worth saving. And one of the ways we can save women's lives and to save girls' lives is to make sure that they have access to high quality sexual and reproductive health services, amongst which we have family planning. That said, thank you for your kind attention. And I think I will stop sharing my screen. Thank you.
Thank you, Dr. Ojong. Oh, wow, this was truly exciting. I don't know how you're feeling, Christelle, but I feel like I'm little, but I feel like the Q&A is going to be an exciting one. What do you think?
Indeed, c'était très intéressant, très succinct, avec des exemples à l'appui. Bravo, Dr. Ojong.
Okay, merci, Christelle. We are now going to get into the Q&A session. For those of you who have questions, comments for Dr. Ojong, you can either drop them in the chat or please indicate with a show of hand on Zoom, and then we're going to give you the floor. While we wait for the questions to trickle in and for people to have the courage to raise their hands, we are going to call on Hyginus Ngasa. Hyginus, sorry for, picking on you. We saw you very attentively watching and following Dr. Ojong's session, and we would like to just ask you to to tell us how you felt, the session went. Like, was it warm? Was it cold? Was it too hard? Because Dr. Ojong can be a very powerful critic. What are your initial feelings about the session?
Oh, hello, everybody. Thank you once more, Dr. Ojong, and thank you previously, Dr. Fuma, for the other presentation on the COVID, which I asked a question about it, and I hope you have some time to address it later on. Oh, the presentation on the family planning to me was like really very interesting. I knew very little about it at the Cameroon level, to be honest. It's something way out of my field of competence. Totally out of my field of competence. I don't have like a daily exposure to the challenges that especially our women back home, but not just them. So I found even the questions which were asked initially really very interesting. Very strangely, I had some of them correct. I don't know how come. So Dr. Ojong actually made a very, very good presentation. At the end, I had a question which it was just coming up in my mind. It concerns mainly when he spoke about the advantages that family planning is going to offer to our women. I was wondering also, he spoke especially about unwanted pregnancy, the health of the mothers, the health of the babies as well. And it struck me that the greater part of these subjects are mainly adolescents. So I was wondering, besides the family planning, which obviously is very important, what is being put in place at the level of our societies, education included, to ensure that we reduce the mortality rate amongst our women, the real stronghold of our communities. So I was wondering what is being put in place to assist them to reduce this this dreadful outcome, and also about the children which may be born from unwanted pregnancies. If there is any collaboration at any level to assist them and to assist their mothers. So Dr. Ojong, thank you very much. I don't know if you'll be able to address some of these questions. There were others which came to mind, but these are my immediate thought. I really like your presentation. Thank you.
Thank you, Hyginus. Maybe before we let you go, would you kindly
Hyginus.
Hyginus. I'm so sorry. Sorry
okay.
for getting that wrong.
That's
so
okay.
sorry.
Okay.
Please, can you just let us know where you're joining us from and maybe what your own area of expertise is?
Oh, my story is long. I'm going to summarize it like very, very, very briefly. I'm a surgeon trained in Italy. I did my medical studies in Italy, did my surgery as well in Italy, worked in Italy for about 15 years. Currently, I'm in the United States. So I'm going through the process of residency, all the stuff. So I live in Maryland, but actually right now I'm in Michigan. For this weekend, I'm just in Michigan visiting friends. I didn't want to miss the town hall of today because the topic of family planning to me is like it's a field I can only learn. So because I'm really honestly very, very ignorant on the topic. So I'm really grateful also for Dr. Ojong for enlightening some of us, totally extraneous to the topic.
Well, thank you. This is exciting. And Hygienist, you might be thrilled to know that, you know, I guess you're aware that there's an association of medical doctors of Cameroon origin here in the United States, and that, you know, we're looking at ways to partner, you know, they're potentially going to be partnering with the town hall, and we hope that you are already a registered member. If you're not yet a registered member, we have a lot of their members who join, and this is a great platform to link up with people and to connect with others and, you know, get registered. So we are truly excited to have you, and we look forward to having you in other sessions. Dr. Ojong, before you answer Hygienist's question, we have one of our members who has been joining us from India for the past sessions. This member of the town hall logs in every fortnight to listen to our talks and to engage in our conversations. Puniteswa Upreti, I don't know if it's possible for you to unmute yourself and say hello to our town hall members. Hi, Puniteswa.
Hello.
Oh, Puniteswa? I know he had mentioned, I see Acho Asensius is talking. Acho, maybe before you take the floor, can we just see if we can get Puniteswa to join us? Because I know his internet at times is a little shaky. Puniteswa, can you hear me? Okay. Maybe he's not able to log in, but just so we all know, we have people who've been following us across the globe, and some have been joining on and off, even from, you know, from the Asian continent, and it's truly an honor for us. He's been a very active member of our town hall. Therese, how about you?
Hi, Allison. I'm good. Hi, everybody. I know it's been a while since I've been here. I've been on and off, and currently my voice is not good, as you can hear, because I've just been on and off, but I'm back. And thank you so much, Dr. Ojong, for that presentation. It enlightened me and a lot of people in the town hall who learned a lot from that presentation. And most of us were even shocked about the 17% and Douala. So I think maybe you can elaborate on that, but yeah, thank you very much. And I'm back, so you're gonna be seeing me more often in the town hall.
Welcome back, Ms. T. We are glad to have you back from your holidays, and from the look of your face, we know that you had a great vacation. We see Dr. Eko in the house. Hi, Dr. Eko. People have been texting me and like, Alison, Dr. Eko is in the house. Dr. Eko, hi. Dr. Eko is the regional delegate. That should be, I think, for the Southwest region. Yes. Dr. Eko, are you here with us? I don't know, maybe if you're speaking because you are muted. Hi, Dr. Eko. Dr. Eko est dans le bruit. It's weekend bruit now like this on Dr. Eko's side. Doc, thank you for joining us, even though you're enjoying your weekend. We really appreciate it. Yes, Dr. Eko, please, you have the floor. Okay, I hear it's a little noisy where he is, but we are glad that he's able to follow us despite competing commitments, and we hope he's having a great weekend. We also see that we have Dr. Quo Marquise in the house. Hi, Dr. Marquise.
Hi, hello everybody.
We are glad to have you. How are you doing today, and how did you enjoy Dr. Ojong's session? And do you have any initial questions or comments for him?
Well, the session was great. I think I don't have questions. This is the first time I am attending this town hall. Thanks to Dr. Ojong gave the invitation. Actually, I'm working with Dr. Ojong. I'm working with UNFPA Cameroon. So yeah, this is our daily bread to make efforts to have family planning repositioning in Cameroon. So thanks for
Well, we're glad to have you. And maybe for those who didn't hear, just because Dr. Marquise's network is a little shaky, Dr. Quo Marquise is with the UNFPA. So we have policymakers in the house, we have implementers in the house. So this is going to be an exciting town hall discussion. I'm excited. Dr. Ojong, I think while the questions are trickling in, I see lots of them in the comment section. I'm going to put you on the hot seat right now. Did you get a chance to grab tea and a cookie or something just to get some energy, because you've been talking for about an hour? Because it's going to be a very engaging one. Are you ready for us, Doc? Okay, awesome.
I'm good.
First question. Yeah.
Please, just before you ask questions, just to say that when it comes to family planning and policy and advocacy, it's not rocket science. It's not cast in stone. I'll be giving my opinions, and there's lots of people in the house whom I can see whose opinions I'll appreciate in case they thought otherwise to me. I mean, Dr. Marquise has just left. She tends to be very humble, but trust me, she's much of an expert on the topic. Dr. Eko, if he can succeed in freeing himself from the noise, he introduced me to family planning. That I must state that. Some years back in 2012, he actually trained me as a family planning provider, and ever since it's been my journey. And I can see Dr. I guess Kingsley Ombakuk somewhere. Just to say, in 2012, he and I were trained as family planning national trainers for the Northwest. So anybody can chip in, but I'll give my honest opinion on what I think, and yes, I can take the questions.
Thank you, Doc. So for those who came prepared to put Dr. Ojong on fire, know that he came prepared for you. He came, not only is he fully prepared as an individual, he came with rank 4. So if you look for his trouble, he's covered. Okay, Doc. I think the first question or first comment that I'm going to make, which comes from comments that I got from other women the minute I put up this flyer on my WhatsApp status, on my social media platforms, the minute this flyer went up, there were a couple of comments primarily from women. They said, one, each time that Cameroonian men don't like family planning. So let's talk about barrier methods. Then most of their men don't want barrier methods. That the minute you start asking your male partner that, please, can you wear a condom? The next thing they're going to ask you now, say, we know the chop banana, like how do you eat a banana inside the skin? You need to peel it. So they say the men are the problem, that they don't understand, that you fight with them. The first couple of times you win the battle, before you know it, the family planning just like barrier methods disappear. And that they tend to prefer barrier methods like the male condom, because with the injectable contraceptives, they complain that the side effects are too many. They will say the injectable contraceptives are hormonal. It makes them to pick up too many kilos. Those contraceptives, the return time to fertility and ovulation and all of that takes too long. So once they stop it and they're thinking, okay, I'm stopping this family planning because I'm planning to have a baby within the next 6 months. At times it takes up to 6 months for their periods to even come back. So they say they don't want to do the injections. And they also have this conception that, you know, the injectable contraceptive methods are hormones. Is there a risk of cancer associated with these injectable contraceptives? So they would rather use the barrier methods. And when they come to barrier methods, they prefer most of the times the male condom. And they say the men don't want to wear the male condom. As for the female condom, I don't even want to talk about that one, because that's like a whole other box of its own. Women are just like, no, that thing is a type. You know, a lot of Cameroonian women, we are not that open-minded. What advice do you have, first of all, for us, Doc, with regards to these injectable contraceptives? And for our men who are either on this platform or who are watching us online when it comes to the use of these barrier methods of contraception?
So that's basically 9 questions in one. But I'll try to reduce it all to 3 things. And then after that, I'll address a question which Hyginus raised, just so that you did not miss out on the fact that he asked the question. So the question you asked, I'm going to target it in in three ways: from a rights-based lens, from a demand perspective, but also from a service provision perspective. When I take a rights-based lens, and I've had a lot of stoning around Cameroon when I start using the rights-based lens, because some people want to think that I'm encouraging women to be, and then all kinds of words start coming up, which is not dignified of me to mention here. A woman's body is first and foremost her body. And Ojong Samuel as a man needs to know that, and every other man on this platform needs to know that, and every other man on YouTube needs to know that, and on Facebook need to know that, and in Cameroon need to know that a woman's body is first and foremost her body. And it is her right to use her body in any way she deems, any way safe she deems fit. It is her right to have access to safe, but also pleasurable sex. It means that if the only way she's having access to safe sex is by a barrier method, say a condom, the least the man can do to accompany his partner on that decision is to use a condom. That is the principle, okay? Now, let's go from principle to reality. The truth is, we are a country that is 60 years old. So we will not act like we are one of the 400-year-old countries. It means that the whole issue of empowering women, the whole issue of power dynamics play out differently. So yes, we actually get to see women who may have unsafe sex, not because they really wanted it, but because the way the power dynamic plays out in our context puts the man more often than not in a position of strength. But look at it this way. If she uses a hormonal method, yes, it may protect her from an unwanted pregnancy, but does that protect her from an STI?
Yeah.
It won't, okay? So what we need to do is to invest aggressively in educating not just the community as a whole, but educating girls and women to know that it is their right to say no if they do not feel that the sexual act puts them in the best conditions of safety and pleasure. It is their right, and it's inalienable. Now, talking about why they may prefer barrier methods and all the myths around contraception, we must first of all agree one thing. Like every other form of medication, yes, you could have side effects. I mean, you could have side effects on basically anything which is medication, right? And I'll be the last person to stand and say with contraception you wouldn't have side effects. So that is why we must generate demand properly. Generating demand properly is not telling women there are no side effects, it's telling them there are, but there are minimal. That is proper generation of demand. It's also telling them there are side effects, but there is no one size fits all. One woman will have a reaction to a method which another person will not have, right? But again, I must insist that the side effects remain rare and minimal, okay? If they were not safe, then they will not have passed various policy attestations to be put on the market. They are generally safe. It's good to state that. Thirdly, it's important to make a difference between a side effect and what may just be, I'm trying to look for the right word, I don't know if consequence is the right word, or logical expectation. Let me say a logical expectation. I give an example, okay? With women using, say, the combined oral contraceptive pill, they may not have a problem of missed cycles, right? Which is something which may be common, more common, not common, but more common with, say, injectable contraceptives. What therefore is the issue? The real issue is at the moment of creating demand and at the moment of service provision, we as family planning service providers need to empower these women with all the information they need. It doesn't suffice to administer a method, okay? It means you tell her, okay, I'm giving you this method, these are the things you should look out for. If you see if I give an injectable method and you do not have your cycles, it's perfectly okay. It could happen with injectable methods. Or if you use an injectable method and then you see spotting, outside your normal cyclical bleeding. If it's not severe, okay, if it's just stains and you're safe and you have no pain and it's perfectly okay. So you prepare them to look out for these signs, okay, which may happen. And then you give them the danger signs. If you have bleeding, if you have pain, if you have this, then you need to consult immediately, because we really can never tell who will present what. But like I said again, at the end of the day, we know that all the methods are perfectly safe. And just so that I don't miss out on this, it's very important at the moment of initiation, especially for hormonal methods, to go through a service provider, because you have eligibility criteria for different methods. Some people, because of some particular health reasons, okay, if you're obese, you're morbidly obese, there's methods we will not want to give you because of risks of heart disease, okay, or of heart complications. If you have a past history of some cardiovascular events, you know, a stroke, pulmonary embolism, there's methods we wouldn't want to give you. If you're about to go for surgery, there's methods we wouldn't want to give you. If you're going through some form of therapy, okay, say if you're on anti-TB medication, or if you're on highly active antiretroviral therapy, there's methods we may not want to give you. So the important thing is making sure that women are screened properly at the moment of initiation. So I don't know if I think that's for Allison's question. And then for the point Hygienus raised, he asked about what is being put in place to really fight maternal mortality, especially looking at those who are most at risk, say like the young girl, the adolescent girl. I think a lot is done in Cameroon, more is done than we are willing to accept to actually fight maternal mortality. The first proof that much is done is that there is actually a program for the fight against maternal and infant-juvenile mortality, or infant deaths, maternal, neonatal, and infant deaths. And I always say, if it exists as a policy statement, then it's already being prioritized, because that's the most difficult thing to achieve, to put it on the policy agenda. So it is on the policy agenda. And there's a whole program, a whole office, which is only in charge of that. Not forgetting the fact that the Department of Family Health must provide technical support to fight that, the Ministry of Health. So there's all this policy action going on, which is saying we cannot allow women and newborns to keep on dying. Sure. However, we have moved over the last, 10 to 11 years from a maternal mortality ratio of, say, 782 per 100,000 live births to 406. It is a win. To some people, or to many people, it will be like, okay, perfect, we are progressing. To me, it's not good enough, because one maternal death is a death too much. That's what I say. Okay. And one thing I think we can do, in addition to what's already being done, you know, in addition to training healthcare providers, in addition to improving infrastructure, in addition to making sure that there's access to life-saving medication, is to have a more integrative approach. I think we have we tend to function in vertical silos, you know, and again, I'm going to blame funding streams partly for that, because these funder comes and they are looking at the women like this. They don't want anything that has not got to do with the women, so they fund for the women. But is there any woman who really wants to go through pregnancy and survive if a newborn is dying? And this other funder comes and is looking only at the newborn. Yeah. Or this one is looking at the child. So funding streams tend to distort our priorities such that we are not having, so all what we are doing does not add up. Everyone is just like in a little cupboard of their own. We need to find ways to actually have an integrative approach in the fight against against all preventable deaths, whether it's maternal or newborn.
Okay. Thank you very much, Dr. Ojong.
Krista, you're muted.
Now I think you can get me. Sorry for that. Yeah. So we have several questions in the chat, and then you have the chairman who raised the hand. So maybe I give the floor to the chairman and then I go back to the chat. No?
Continue with the chat, please.
All right. Thank you. So let me call on Dr. Eno Stevens. You have been very active in the chat, raising several points. It's like a topic very close to your heart. So I think you are the best person to speak out about your questions and then have a response from Dr. Ojong. Please present yourself, where you are dialing from, and then go ahead with the questions.
Thank you very much, Christelle, for the opportunity. Eno, I work with IPPF at the regional office in Nairobi. It's called the International Planned Parenthood Federation, and we have CAMNA4 as a member association. I'm the youth advisor for youth and SRHR programming at the Africa region, and I manage reproductive health projects in 14 African countries. So I'm quite excited to see that it's my big brother who is presenting on the family planning, and he's now the focal point. And I think that we have become more progressive than conservative in family planning in Cameroon. I raised a couple of questions in the chat box, mostly on the financing family planning commodity supplies, because in your presentation, I realized that indeed there is no harmonized intervention to maintain a good supply of family planning commodities. So one of my questions were, what strategies does the government or Ministry of Health has in place to make sure that we don't have stockouts or stocks left, as you rightly said? The second one was around access to family planning commodities to young people and adolescents, because again, stigma has been a problem. And I think that young people are yet to receive a full range of family planning services in our hospitals and medical facilities due to stigma. And so what strategies are put in place, maybe from the family planning unit, to make sure that young people and adolescents have a full range of family planning services without being stigmatized or judged, as you rightly said, in terms of a right-based approach. And I think lastly will be about renewal of policies and commitments. I'm very happy that my country is my country endorses and really makes sure that the push for good commitments like the Maputo Protocol, the ICPD Convention, and even the FP 2020 and now FP 2030, which the government of Cameroon is pushing forth. But what about national commitments? I see most of them are outdated. 2012, 2020, most of them ends at 2020. Are there any rooms to renew these commitments or look at what worked within this commitment, what is not working, and what can be improved? So critically, those were my 3 questions, which I look forward to getting the answers. Thank you very much, Dr. Ojong. I'm looking forward to see that as a young clinician, we're going to have a more progressive language around family planning, but also around sexual and reproductive health in Cameroon. Thank you, Christelle, and over.
Thank you so much. Dr. Ojong, you have the floor, the big brother.
Yeah, once Stephen took the floor, I knew he was about to put me on the hot seat, because he's been on sexual and reproductive health for close to a decade. And I don't say it to please him. I am yet to find a Cameroonian who is more passionate about sexual and reproductive health than him. He's been around the world for sexual and reproductive health ever since he was a young medical student, and I'm happy to see him sit at the top in Africa and representing Cameroon, and hoping that we can have him share on the town hall his experience one day. This is me already advocating for him. He's such a brilliant mind. I'll begin from the end, because everything starts from there, governance, leadership. And he wanted to know, why do the national commitments seem to lag behind? Why do they look like they're outdated? Why? Because I'm a sexual and reproductive health person, I spend my whole day looking at it and trying to tell the government why I think it's a priority, right? However, those who make the decisions at a much higher level than me are not receiving input only from me. So they receive input from malaria, they receive input from HIV, they receive input from cancer, and then beyond health, they receive input from food and nutrition services, they receive input from infrastructure. So because of all of that, they must prioritize. There is nothing we can say about it. We have limited resources. We are a middle income country. We must prioritize. And I think one of the reasons why sexual and reproductive health tends to suffer a lot is because of the really strong implication of foreign partners, okay? Partners finance sexual and reproductive health by over 95% in Cameroon, which is a good thing in the sense that the financing is made available. But it's a bad thing in the sense that some people who make decisions tend to feel, okay, partners are already there. There's no reason why we should mobilize more funds because there's already partners funding that. But what they sometimes fail to understand is that there is no partner who can really fund all your needs. Partners are just what they are, partners. So they come in support. So I am one person who believes if you take out partners, our sexual and reproductive health framework in Cameroon may crash. Because like I say, it's 95% funded by partners. And because they are the ones funding, and the funds cannot meet all our needs in terms of sexual and reproductive health, what do you think gets prioritized? Operational level stuff. Train, buy. But there is really higher levels, there's really higher level processes which people miss out on, like advocacy, like monitoring and evaluation, like impact evaluation, like redoing the plans, reading the plans, because we all get caught in this trap whereby we think we need the partner to come and tell us, okay, now your strategic plan is expired, so we're going to fund the next strategic plan. So it's shocking, but those are some of the gaps we need to address. We need to take some degree of responsibility, you know. And when I say we, because I put myself in that bracket, I'm not saying them, we need to take some degree of responsibility. Partners now have been behind their back for the last 1 month saying we need a costed implementation plan for family planning, right? Because it's a costly procedure. I bring to bear on the state, but I also bring to bear on partners. The important thing is let the funds be mobilized. So I think that's one of the reasons why our national programs and plans sometimes, you know, get outphased, or sometimes by the time it's ending, there's really no impact evaluation done. And so it's hard to start a new plan. He talked about harmonizing the intervention with respect to financing for family planning commodities or for reproductive health commodities. Again, I'll say I am happy the partners are helping and they're doing a great job. And right now, I don't think we can really succeed in this space without our partners. But our biggest joy is our biggest weakness, partners. Our overdependence on them means each time they have a hiccup, we catch a cold, okay? So I give an example, UNFPA is wonderful. You know, they almost 90% and above of what we get as reproductive health commodity comes in through their intervention. But what happens if there is office procedure that delays a little bit, so funding should have been available last week, can only come in 2 weeks' time? We'll have to have a 2-week stock up, okay? What happens if UNFPA brings in all these commodities and they are at the port, but those at the level of the Ministry of Finance have not mobilized the funds enough to pay the relevant taxes or to ensure that the relevant taxes are, as they are spared the relevant taxes linked to these goods? The goods will stay at the port for 9 months. And sometimes by the time they are leaving the port, they are near expiry, you know, because someone did not do what he had to do, okay? So we have it's a huge governance issue. It's us, it's all of us, really, it's all of us. And we must all think about innovative ways to achieve more. And that's why I mentioned an initiative. I can't go into details on this platform about that, but I can say the UNFPA Compact is an innovative financing system where the UNFPA is saying, okay, up till now we have functioned through gifts and donations. Now we need you to take responsibility. And taking responsibility is, if we're giving in this, then you should be bringing in this. When you start feeling the pain of the purchase, then you will also feel the pain of an expiry and you will take more responsibility. And I totally support that. Finally, with respect to adolescent or young people's sexual and reproductive health, yes, we have a big gap. The gap is not because the state doesn't want to protect them. There's a lot of policy documents. And that's what I love about us. We do not lack the policy document upon which we stand and do the right thing. They are there in abundance. So it's really a good first step. It's a great first step. And in addition to policy, there is at least 10 to 15 adolescent-friendly clinics that have been launched over the last 1 year alone across the country, because we are gradually accepting that you cannot provide rights-based comprehensive sexual and reproductive health services to adolescents and young people within the same space that is receiving adults. It's a huge barrier to them. So we are investing in those services. There's also mobile clinics, which partners have supported us with, which are essentially built to support adolescent-friendly services. There's a lot of advocacy action going on. Trust me, a lot of advocacy action. We must just be conscious of the fact that we have our sociocultural realities, which do not easily throw sex education and sexual and reproductive health empowerment towards young people. You're all witnesses that about a year or two ago, there was a huge outcry at the attempts to bring in comprehensive age-sensitive sexual and reproductive health education into schools. But that's just it. We must accept that in 2022, what my father did not know in Akombeng village, my son, who is 6 years old, now knows with one click of his father's phone. So I must protect him with the right information. But we cannot force it on the people. We must educate and through advocacy, build the right critical mass where it becomes okay to empower people with the right kind of information for their age. I think that's the little I can say. And of course, I'll accept contributions from others in the room who are also intervening in that space.
Thank you, Dr. Ojong. And talking about contribution, I saw recently Dr. Marquise raised the hand. I don't know, maybe as a partner, she might have a contribution regarding the position of the UNFPA in the family planning nationwide. I don't know, Dr. Marquise, do you want to comment on what has been said?
Yes, not really as a UNFPA nationwide, but I just wanted to add some additional comment on what Dr. Ojong said. First, I want to congratulate Dr. Ojong. He's a great speaker. I'm discovering that. So I just wanted to add, to make a comment regarding education of girls or women on reproductive or family planning, and wanted to emphasize on the fact that we need to educate young boys. We need to this is a paradigm shift we need to have in our society. We need to really implement what we call gender transformative and to educate social norms. I cannot address social norms early in the lifetime. We cannot succeed in creating demand in the family planning. So as a UNFPA colleague of Dr. Ojong, I want to advocate and that the Ministry of Health and all the ministry engaged, such as youth education and so on, need to address the family planning education towards young boys. This is what the additional comment I wanted to do. And thank you, Dr. Ojong, for making this today and letting everybody know about all the initiatives. I just wanted to say that family planning as an intervention, as an I hope you come. But family planning as an intervention of reduction of maternal mortality is one of maternal mortality in Cameroon is one of the angle the government is taking to, advocate for more funds. So maybe we need to know that family planning is one of the high intervention for the reduction of maternal mortality. And Dr. Ojong said that one maternal death is too much. So we also have to keep it in mind to link family planning with tradition and maternal mortality reduction. Thank you.
Thank you so much. Thank you for your contribution. It's really welcome. So the first part was a bit interrupted, but the key message is about education of young boys, of young girls, not only in the family planning department, but also with other ministries dealing with education. And since we are talking about education, in the chat, we had one question from Martel Juvet. So he was wondering, it's true during the presentation, you said there's training of healthcare providers sometimes during a session. And then he was wondering whether is there a formal training for healthcare provider on family planning in the country, not only maybe during workshops or webinar. So could you comment on it, Dr. Ojong? Thank you.
Okay, so we always start with what is going on right, and then we indicate the gaps and maybe ways forward. So with respect to what's going on right, yes, there's a lot of training that has been going on over the years. Like I said, my first contact with family planning was in 2012 when I was being trained first as a service provider and eventually as a national trainer. And that was something I never saw on my med school curriculum. It was really independent investments or initiatives by the state and her partners. And there's a good number of partners over the years and a good number of initiatives who have accompanied the state to make sure that we are trained in these skills. Again, the funding is mostly from partners. That's the first thing we must indicate when it comes to this prompt initiatives, which consists of training people who are already on the field, capacity building in healthcare workers. But one good thing the state is increasingly doing, which is important, is introducing sexual and reproductive health modules in all training schools. So I went through med school, for example, and while I knew the theory of family planning, it was not obligatory that I learn how to place an IUD or a dermal implant. It was not obligatory, but now it's part of the curriculum in all training schools. Sexual and reproductive health modules are introduced in there. So it means more and more people come out of school with the skills, and not just for family planning, but also safe abortion care. So it's really lots of maternal and child health interventions which are being incorporated into the training models in schools. Secondly, talking about the training we receive, which is the most common model, which means inviting in workshop setting the different healthcare providers. It's a great thing. I mean, training one staff is always good. Workforce capacity building is part of health system strengthening, so it's laudable. But I think we can do better. In what ways? You realize that when we were trained with Kingsley, for example, we're 30. So it was 2 people per region and maybe 5 to 10 from central level. So that made 30. But let's just say 20 from the regions. When we were trained and sent back, look at it. Kingsley was in Santa, I think, and I was in Fundong. Fundong Health District alone has how many health areas? In fact, the Northwest has how many health districts? About 10 to 11. So if you train 2 people, 30 looks much inside the same workshop room. But once you send them back to the region, what have you really achieved? Very negligible, right? And so I feel like with the same resources or even less, we can invest in innovative training strategies, which consist of sending the experts down to the health facilities, but not just to train in family planning, because remember what I said, we need an integrative approach to sexual and reproductive health. So the same person will capacitate these workers on family planning, on newborn resuscitation, on infection prevention practices, on safe abortion care, So when we do that, we will spend less and capacitate more people. In the long run, even if 1 or 2 people are moving because of transfers, because of this or that, the health facility retains some degree of capacity building with minimal spending. So that's my opinion when it comes to training.
Great. And then I see in the chat also reinforcing the training in the training school about family planning in midwives, medical doctor from Dr. Makis. So I will switch to from the chats, the hands that are raised. So I'll call on Georges Come. I hope I'm pronouncing well. Please, can you unmute yourself and then present us where you are dialing from, what you are doing, and then ask your question. So maybe we can take 2 series for you and then we move forward. What do you think about Dr. Ojong? So Dr. Come first and then Dr. Foma after. Then you can reply after, I think. Thank you. Dr. Come, you have the floor. You're unmuted, but we didn't get you. I hope it's not from my end.
No, I can't hear him either.
Okay.
George Come?
So, no response. So on the meantime, before we get him back, Dr. Foma, please, do you want to go ahead?
Yeah. Thank you very much, Ojong. As usual, always very excellent presentation, but I must confess that the ministry has started affecting you a bit because I could feel that, so I have to say that. So I've known Ojong for more than so many years, so throughout our whole adult years, so right from medical school. So, well, Dr. Ojong, I have several questions really. Goes back to the first being, I'm going to go into maternal health, and Dr. Makis took that question from my mouth, meaning, do you think that what Cameroon has done prioritizing in terms of more in terms of looking into reproductive health, has it helped in reducing maternal mortality in Cameroon? You know, our numbers were alarming just some few years ago. I think it was alarming back in the early 2000s. We're almost at 782 per 100,000, which back in the early 80s, we're almost doing quite fine before you had the great economic crisis that took over all of Africa. So what has led to these changes, this drastic reduction that has taken place over the past few years in terms of maternal mortality? Infant mortality has not followed suit like as much as maternal mortality. You think this strategy is something that is going to help in the future going forward? And do you think we have a strategy in place which we can really help reduce maternal mortality by advocating for reproductive health? And when it comes to practical things you can do, what method do you think needs to be prioritized in Cameroon? Meaning, what method do you think we need to advocate for? And do we go with all the methods and SWAM? Do you think we're ready to get all the information in terms of offering a woman a salad of methods? Or do you think we should prioritize these methods based on our economic setting in such a way that we can be sustainable? Then there is an organization in Cameroon that once I moved out of Cameroon back in the late 2000s, I went to Ghana. A lot of people were talking about Sang Jeune and the way they fought HIV. I know you talked about NGOs, local and all of that. They were like a model in Africa, meaning they were taught in schools in Gimpa, in Ghana. They taught the model which Sang Jeune used in order to communicate HIV communication. Is there any strategy like that? Is there any NGO like that which is trying to integrate all of this kind of information? And being in the ministry right now, what do you think you can do personally? What kind of changes can you make personally in terms of moving this agenda ahead? You are one of the young ones with a vibrant blood coming out, and we think I always believe, I always say the young must grow, including myself. I have several juniors, but I always say the young must grow. We train the young people. It's only in Cameroon that we have the mentality that we train people to block them. We train the young people to make them better than us. And once they're better than us, then we gain pride in it. So I think that's some of the things I just wanted to know. Then talking about side effects, I was just churning a bit. There's a lot of talk really about side effects of contraceptives. A lot of them are different. As just talking as an oncologist from an oncology perspective, there is some data that some of them may increase or reduce the risk of cancers, but overall they are better in terms of cancer reduction. So there is some little data, there are multiple data, but when you do some meta-analysis, you could see cervical cancer could be increased slightly, but there are multi-factors. Is it because those women do not adapt using of condoms when they get oral contraceptives? So, and having multiple sexual partners, is it just a problem of data that is not well, confounders getting in, or is it, but even analyzing those confounders, we tend to find out that there is a slight increase, not something that could discourage you from offering that method to a woman. Breast cancer also, there is a slight increase depending on what kind of contraceptive you take. Could increase or decrease depending on if you're taking dual or single, but there is slight increase, but there is reduction of ovarian cancer actually documented too. There is also reduction of uterine cancer because you get exposure to hormones. Now, the more you get exposure, some of this, the less you get exposure to hormones, the more you have like a early menarche, and that you get ovarian cancer. So it's one of those things that we need to talk about to our patients, get ourselves educated. But I don't think, in general, if I'm advocating for this, I'm not an OBGYN. I would say the data that we have in terms of cancer is really, it can go both ways, but it's minimal. It's quite minimal. So Ojong, I wanted that, I just said that was a little contribution, but those were my little discussion. But you're getting very, I must confess, you're getting very good at it. Okay, Dr. OJ.
I am amazed that you will think I've grown soft. I've actually grown harder. I just refuse to be that one who will be talking about family planning and shifting the blame to others. You know, we say that administration is continuous. I am part of the family planning landscape in Cameroon, so I am as responsible for the failures as any other person. And so maybe the softness in my voice was the mea culpa, but maybe I need to talk now as Ojong Samuel and not as family planning focal point. You mentioned something which we should be very cautious about saying that. To say that our maternal mortality statistics were better in the 80s, you need to show me the data. And I don't think we have worse data systems today than we had in the 80s. They are not good enough yet, but I think there's some degree of being better today than in the 80s. I stand to be corrected by those who have been practicing since the 80s, but I think health information is one of those areas where we've moved half a step forward compared to the 80s. So yes, the figures may have been showing something less, but I don't think we're capturing enough of all what was happening as maternal and newborn or child deaths. Now, you also mentioned about, you talked about the fact that the drop in maternal mortality has not been followed by a similar drop in newborn or in child mortality. And I've raised this question sometimes because I've said, when you look at the program for the fight against maternal, newborn, and infant mortality, it is the same interventions. Okay, it approaches the mother and the child as the couple. So how come you're saving the mothers and you're not saving the children? And for me, I bring it down to one painful answer. The child is not much of a policy priority. We say it, I don't know if we are conscious, but we obstetricians tend to say it is better to lose the water than to break the calabash. And we have so said it that we have gotten used to the idea that it is shocking for a mother to die, but it's not that bad if it's a newborn or a child that dies. And unconsciously, our practices may have followed that policy belief, that inherent sociocultural belief that we can always replace the water provided we have the calabash. So are we really capturing what's happening in child health as much as we are capturing what's happening in maternal health? I can tell you for a fact that each time there's a maternal death in Cameroon, there is the tendency to carry out an audit, not same for newborn, not same for children. So if we are reviewing maternal deaths, again, there are huge gaps in the audits, but at least we're doing that. We're doing reviews, we're doing audits. If we're doing that, then we are able to identify what went wrong and to find ways to improve. So it's clear that maternal health might be improving because we are auditing every death. But if we are not trying to look at why our newborn are dying, how do we arrest the bleeding? For example, if you go to DHIS2, it will not only give you the numbers of maternal deaths, it will give you the causes. So she died of hemorrhage, she died of infection, she died of this. But if you go and look at newborn deaths, it just tells you when they died, no cause. So we can give you what number of newborns have died, but we can't tell you why they died. Therefore, we cannot know what to do at the policy level to arrest the deaths. So what's happening? Newborn deaths are more or less stagnating. But we are not even capturing the reasons why they are dying. So how do we make the decisions that save them? So that's how I'll approach that. Again, for those who rejoice about the drop from 782 to 406 maternal deaths, I always say, let's play a little statistics game. Go and look at confidence intervals. You realize that we have stayed in the same confidence interval. You know, if you look at the absolute number, which is what we give the policy makers, because you need to make them smart sometimes, there's been huge improvement from 782 to 406. But look at the confidence intervals, where the 782 fell and where the 406 fell. We are really within the same confidence interval. We haven't really changed as much as we ought to have changed, considering all what is being taken as initiative. And whose responsibility is that? It's ours collectively. And this is not me being soft. This is me being real. Because you asked that if we had to just do one thing, one intervention to arrest the situation, what do we do? Unfortunately, there is no one intervention. There is no magic bullet for maternal mortality or for newborn, or for child mortality, newborn. There's no magic bullet. It's a series of things that need to be done. And I'll narrow it down to two. We need to strengthen our health system. Our health system is not resilient enough. How do I know? Look at what happened in COVID year. In COVID year, we had more unskilled people do C-section than out of COVID year. Why? Because the specialists could afford the luxury of saying, I'm not going to expose myself to COVID. And it left a huge gap in terms of who was now doing a C-section. It means our health systems are not resilient. That's just looking at the workforce. So we need to strengthen our health systems, strengthen leadership, strengthen health financing, strengthen service delivery, strengthen our health information management systems, look at access to essential medications and technology. We need to strengthen that. But if there is one magic bullet we need to succeed in Cameroon, is to strengthen our community health. You know, we all say we practice primary health care, and I don't know how it has escaped our attention that we really do not have community health. And each time I've raised this, I've had DMOs, I've had people tell me, no, we have community relay agents. No, that's not community health. It's that those are people involved in community interventions, but we do not really have service delivery at the community level. We do not really have a health system which is cognizant of the community realities. The proof is we capture maternal deaths in hospitals in a country where we still have about 20 to 30% of deliveries occurring at home, but we do not capture those deaths in the communities. It means there is really no community health. That's just taking just maternal mortality. We could go into more deeper dimensions of it. So I'll say strengthen community health and strengthen our health system, and it'll go a long way to help us in the fight against maternal mortality and child mortality.
Sorry, before I give my mic off, I just want to ask, do you think we're dealing with all the 3 delays? I know our talk in maternal mortality has always insisted on the last, which is at the level of the facility itself providing adequate care. Now, the other things that happen before this woman comes over, our infrastructures and reach out. So all these things are there. Is this why you think the confidence interval has not shaken? I gave this statement because I was one of those who was trained in the initiation of this thing when I started going back into residency. I think Umbaku called me in for a training with Professor Mbu. I had to get some ADM, so my name was added to it. I must say it loudly. But it's very important that we turn to know that it took us 20 years to cancel the training of midwives in Cameroon. It was not done for 20 years. A lot of maternal interventions were suspended for years. Partially, there was no training schools. The one in Bamenda was suspended. No one trained midwives for so many years. My mom was a midwife, but they never had successful midwives trained. They were trained in the early 70s or late 70s. And in the 90s, no midwives were trained. Several other interventions to help reduce maternal mortality. But this is just a statement. I want to give time for the others to talk about this. It's a topic I hold dearly. And I think, like you, even one woman should not die while giving birth. So thank you very much.
Maybe I shock you a little bit. There's those who believe that the first or the second delays are not as addressed as the third. It's my opinion that none of the delays is addressed, and that every woman who doesn't die is just a lucky near miss in Cameroon. Now, that's my opinion. That's not government talking. I'm not even qualified to talk on behalf of government. I'm just a worker. Why do I say so? For as long as women still need to travel 30, 40 kilometers, 12 kilometers on very bad roads to access health, essential healthcare services, you cannot say we are addressing the first delay or the second delay, okay? For as long as women still have to pay out of pocket for essential care services, it will be very hard to address those first 2 delays. Okay, for as long as even when the healthcare provider receives her, even when she comes on time, okay, for her to get a C-section, she needs to pay for a kit or go pay for some workup. Or for as long as we're still talking, we're not talking about universal health coverage, for example, we are not really addressing the delays. We need to stop having a clinical perspective of these things and look at it really from a public health dimension, from a policy dimension. Because remember what I've said, science will give you all the evidence, but only policy really saves lives. Okay, so I think that we need to address the health system more from a holistic viewpoint. Look at something, which women are dying? Because it doesn't suffice to say we had 1,000 deaths, but who are the women dying? It's the unemployed women, it's the women in the rural communities, it's those in the most hard to reach areas, it's the single women, it's adolescents. We have a cartography of who is dying. So what do you do to address this? Why are the adolescent girls dying? Because they don't have money. They don't have the support of a husband to pay for their care. It's not as if every married woman's husband pays, okay? Why are the rural women dying? Because the local hospital in the community is not as equipped as the one which is 20 kilometers away, and she wants to be safe. How do we bring care closer to the women? I think there are countries like Mali and Rwanda who have strong, robust community approaches for maternal and neonatal health from which we can inspire ourselves. And that is what we are doing. That is what we can do from within the ministry to stand and use every opportunity to advocate, to say, you know what, we don't need to invent the rule. We can just copy from where it is already being done right. And that's what I do now. I don't just criticize, but beyond criticism, I say, see, you know what, this is what I think can be solutions.
Yeah, you finally answered the last part of my question. Thank you.
Thank you for the great exchanges and answers. So we'll come back to Dr. George. I think we'll take a series of 2 questions. So we'll take George and Alison, and then Dr. Ojong, you can respond after. Please, George, try again and present yourself. Tell us from where you are dialing from, and then ask your question. The floor is yours.
Thank you very much, Christelle. I hope it's better now. Thank you very much. I'm George Jedepa Nkome. I'm a general practitioner. I actually moved to the US 7 weeks ago from Cameroon, so I'm still looking for my bearings here. I would like to start by thanking Dr. Ojong, whom I know so well because we worked together in the Northwest. Because though a GP, I worked a lot within the context of the HIV project. And that's in the context that I would like to ask my question, because as he knows very well, since the onset of tritherapy in treating HIV positive pregnant and breastfeeding women, family planning became an integral part of counseling at the HIV management units. However, unfortunately, like he rightly said, as concerns funding, the funding partners who carry out the follow-up of the HIV positive clients provide some aspect of the package for family planning, which is just condoms, both male and female. And consequently, there is no integral package. Secondly, usually the treatment center staff have no training as concerns family planning. And thirdly, usually the family planning unit is further or really far from the treatment center. So it creates a challenge, usually for those clients who would like to receive this family planning, because remember with tenofovir lambda variants, there were problems. Even with the new protocol of tenofovir lamivudine dolutegravir, there are risk of neural tube defects. So all these bring in the aspect of how important it is to have family planning being integrated in following up clients. I would like to know, Doc, since now you are at the dining table, is there something being done for this integration to be done at the level of HIV management unit, so that that family planning, the lessons, everything is done there, rather than sometimes sending those clients who would never go to these departments over? Thank you once again, and it's a pleasure joining the town hall today. Thank you.
Thank you. Thank you for your questions. So before Dr. Ojong answer, it seems we have Dr. Eko back and the hand is up. Please, Alison, with your permission, I think we should take Mr. the Delegate and then ask his question. Please, Mr. the Delegate, you have the floor. Dr. Eko, if you are speaking, your mic is okay. Great. Thank you.
Okay, thank you very much. I don't know whether you get me.
Yeah, we can hear you, Doc.
We do.
Okay. Thank you perfectly. Sorry, I missed part of the, practically the general presentation of my able Dr. Ojong Samuel. I want to speak on 2 folds. The first fold as an OBGYN, and the second fold as a representative of government in the region. As an OBGYN and as somebody who's worked a lot in the aspect of family planning in the region, there are certain things that are a little bit differ with some of his response. Of course, as he said, it's not government. There are certain things that he spoke for himself. I want to think that we've improved a lot with respect to family planning. From when we started practicing OBGYN till now, we've gone a long way. And there are many things, of course, that we need to do to improve more. Family planning related to maternal and neonatal death is something that we'll continue to talk about, even though we do everything possible to analyze, to audit, or to review all maternal deaths and all neonatal deaths and present their causes such that we can respond appropriately. That is what I do in my region, and I hope that that is what others do in their region, because that is what the government strategy is I want to state here to the presenter and to others that, of course, Cameroon worked more on hospital-based medicine, but strategies have been adopted to focus a little bit on community medicine because we who did community health as part of our specialty in public health have tried to advocate with government to know that community health is one of the major strategies to combat majority of problems with respect to our society. And that is what is. About a month or two ago, the Minister of Public Health himself launched the National Strategic Plan 2021-2025 for community health in Cameroon. And this strategic plan has a long way to target most of these problems, especially maternal death. And of course, we know that family planning is the center pillar to fight maternal death. So family planning is one of the major things that Cameroon has put in front to fight maternal death. I want to respond again to the last speaker with respect to the integration of family planning and the management of HIV patients. Of course, that is what we are trying to do. That is a new strategy to integrate the two services such that the problem of stigma will not exist, such that patients will immediately have access to family planning service, integrated family planning service, and general family planning service, not just condoms. So that is what is being done in most of the hospitals now, and we think that is being integrated. And even all the trainings that we do, we try to train all those who are working in HIV setting. But again, what we are advocating again regularly is that family planning should be like what we do in ANC consultations for the test of women, of pregnant women for HIV, provider initiated. We say it should be provider initiated at every part, at every sector, at every entrance of the health facility. No matter what you come for, family planning should be initiated by the provider. We shouldn't wait for somebody to leave and come for it. The provider should initiate one or two questions. And again, it becomes very easy to know whether this person needs a family planning method or not. Dr. Ojong talked about the universal health coverage. Of course, all of us know that that is a major plan of government now to put in place universal health coverage. And we are trying to equip hospitals to put them at a certain level in such a way that practically all the hospitals of district level should have practically the same services, of central level should have practically the same services, and again, of referral level should have all practically the same services. And we are recruiting the hospitals that will start the pilot of universal health coverage. Of course, universal health coverage will go a long way to help us to have access to care and, of course, access to family planning. I heard again many things about the 3 delays, that the first and second are, I would say, not really taken care of. I want to a little bit differ with that. It's not because somebody took 4 hours or so to reach a health facility, it means a particular delay is not taken care of. Sensitization is going on regularly in the communities and everywhere, that we think we are trying to capacitate persons to know how to identify risk factors, especially when they come to hospitals. But again, we do outreaches, we do advanced strategies, go to the community and talk to them. We have community health work. We have even associations and NGOs that are working with us at the level of the region, and we send them to different communities to assist government in passing on these messages to persons. Of course, yes, I know that as of now, there is a handicap with respect to finances. There is a handicap with respect to financial accessibility to care. But I think in a short while from now, depending on the strategy that government just launched on community health and again on universal health coverage, I want to think that many things are being looked into. So we shouldn't think that, yeah, we have a lot of problems. There are still problems to be addressed. But I think for the time that I have been part and parcel of family planning, not only practicing but training providers and training trainers on family planning, I think that we have gone a long way. We have gone a long way, even though there is still much to be done. We have really, really gone a long way. So what I would just want to say is we need more. We need more support. We need the strategies that government has put in place on community health and on universal health coverage to start as soon as possible. I think most of these things will tend to be limited. But again, I want to think that most of our problem is just that providers don't initiate family planning. They wait for individuals to come that they need family planning services. Because even immediate postpartum family planning is a big problem in our community. That is one of the strategies that we started capacitation and think that many persons will buy that idea. But again, many are not trained on that and many don't initiate family planning. Even in immediate postpartum, they wait 6 weeks and above. And many persons, when they leave the hospital, they cannot come back for family planning services. So I think the strategy, Dr. Ojong, is at the central level. Of course, he is the focal point now with respect to this issue. I think he can easily develop the strategies that he knows are the handicaps for family planning. Of course, that we are used to talking together to see that most of these issues on family planning, the prevalence should increase. The uptake of family planning should increase. And of course, if it increases, it's very certain that our maternal mortality ratio, because that is another problem, it's not an absolute value. We should know that we are talking about the maternal mortality ratio, which of course, it will practically not change if maternal death reduces rationally with neonatal death. Maternal mortality ratio will not change. But obviously, if there are that differences between the maternal death and neonatal death, then certainly our maternal mortality ratio will certainly change and will be what we are having now. I'm thinking that we've had a maternal mortality that has reduced. That is the problem that we are facing. So I think that is the contribution that I can make. I think I will continue to listen, and if there are anything that I have to come up again, I'll certainly come up. Thank you very much.
Many thanks, Dr. Eko. So for those who don't know him, we just had the pleasure to have the contribution of Dr. Eko, who is the regional delegate for public health in the Southwest region. And usually he's one of the members of the town hall who usually die in and either in the brewery or not, and then contributes for our session. So thank you for your contributions, for answering questions raised before, and for giving some hint about what to do next to the focal point of family planning nationwide. So I think we should move forward, and then I'll give the floor to two persons, Acho Ascensios and Mr. Tonga Calvin. So please, you present yourself, you ask the question, and then Dr. Ojong might respond after. You have the floor, Acho first, and then Tonga next.
Christelle, if you don't mind, I'm sorry to interrupt, but I just want to chime in. It's very important, just so that we don't miss on something which I think I need to state. First of all, I thank. I call him Repace. I call him Father, Dr. Eko, for chiming in, and it's always breathtaking to listen to his contributions. And I wouldn't add what he said with respect to the plan for HIV and family planning integration. He's very well placed to know that, and it's very true. And I wouldn't comment on much of what he has said, which I agree to in principle. But there is one aspect I don't want to let pass, which is provider-initiated family planning. I think that's one of our biggest problems in Cameroon, because provider-initiated family planning is a reproductive health concept. And ever since 2015, we are moving away from reproductive health towards sexual health and rights. It looks like a game of words, but it's not. Reproductive health is physician-centered. The doctors, the healthcare provider makes the decisions. The healthcare provider is in a position of power. You know, we determine where there is a problem. So it's disease-oriented, okay? So you see a woman and you don't see her holistically. What you see is that she's in her fifth pregnancy, and so she needs family planning because after this, she's a grand, you know, so we define people by pathology. It's really right. It's really disease-based. On the other hand, sexual health and rights places the person at the center of the equation, empowers the person to make an informed decision, to make an uncoerced decision. And I think I'm a little bit properly placed to say a lot of family planning in Cameroon is coerced. And which is why, in the long run, those who are following the theory by which family planning is some scheme from outside to control our populations at whatever cost, they thrive on this fact that we seem to act like we are coercing patients into receiving family planning. And that is why I identified that one of the big gaps is in our communication strategy. We cannot wait for people to receive family planning information from hospitals. Then it is too late. Because remember that from when you provide the information to when she accepts a method, if consent will be valid, then this person needs time to think over and make an informed decision. So if we have to wait for ANC or delivery or postpartum, or considering that how many people have 8 antenatal contacts like we expect, how many of these women are delivering in the health facility like we expect, how many of them are coming for postnatal consultations like we expect. So yes, we should use every contact with the provider to further educate, but initiation should mostly be by us having a strategy that generates demand, and that is massive communication. We need to have behavioral change communication at community level. We need to be communicating through the mass media. We need to be communicating through innovative media. Okay, how many adolescent girls are coming to the hospital to listen to hear about family planning? I can tell you that there is healthcare workers in Cameroon. We're from doing a training 2 weeks ago in Bankomo, and there are healthcare workers who feel it is inappropriate to teach adolescents about family planning, except they have parental authorization. So how do we reach these groups if we do not have innovative strategies which generate demand? So yes, they come and we perfect the knowledge, but we need to create demand. And I think we cannot just depend on the provider to initiate that. We need to have a more massive strategy when it comes to education. That's just what I wanted to chime in.
Okay, thank you, Dr. Ojong.
Yeah, if you permit.
Okay, without waiting, I think Mr. Acho Ascension, sorry if I'm not pronouncing well.
Christelle,
and
maybe before Mr. Asho takes, Mr. Asho, please give me a minute. I don't know, Dr. Eko's hand was still up, so I don't know if he had something else to add. Okay. That he was unmuted. Dr. Eko, did you want to add something?
Yes, thank you very much. Not really adding, but I just wanted to precise. Provider initiated is not necessarily only in areas of reproductive health. Provider initiated is at every portal entry in a health facility. Means whether you come for fever, malaria, or anything, there are 2 questions to ask. First, whether you've started having sexual contact, and secondly, whether you're ready to be pregnant. With those 2 questions, we know your desire or a need of a family planning method or not, and the counsel is for family planning, and it takes the time that of course, he said, we can start fast into the community, we can start in mass media, but of course, I think Dr. Ojong knows more than me that the right things, if that are passed on mass media, are very little listened to by the general population. What they listen to is mainly what is erroneous. So it becomes very difficult, even in mass media, to pass on such information, even though of course, we don't hesitate passing the information through all the channels that are possible to do. But if we can initiate it at every level, I mean, every level in a health facility, then I think we'll capture so many persons. There are many persons who come to hospital. Of course, and that's what we talk about unmet needs of family planning. They need family planning, but either they are not enlightened, they don't even know that they need, or they need and they cannot have access to for one way or another. So there are many ways that we can do to try to enhance the coverage, family planning uptake. Of course, me being a reproductive health expert, me being a community health expert, and of course now the regional delegate, in my region, I'm trying to do more of what I think is required to improve uptake of family planning within my region. National level, it might be difficult because there are certain things that might be difficult to implement at national level. But as Dr. Ojong himself knows, within my region, there are many things that I'm trying to change as concerns uptake of family planning and all other sexual and reproductive services. Thank you. I think I raised my case.
Oh, thank you so much, Mr. Delegate. You know, my colleague and I were just texting back and forth that it's interesting listening to senior colleagues talk, and that when the delegate himself is in the house and he has some insights, you know, we would love to hear them. And I'm sure that Dr. Ojong definitely has some thoughts about this, but I guess maybe for the interest of time, we'll take like one last question, and then we wrap up for today's session, and other, you know, further discussions around this matter we can continue in the parking lot. But these are really engaging discussions, and yeah, we really appreciate these discussions and the contributions. Maybe we'll have a last question or comment from Achuo Asensius. Hi, Achuo. Sorry for cutting you in the last time. It's just we noticed that the delegate's hand was up and we wanted to give him the floor. I'm so sorry.
Thank you, Alison. Good evening to everyone. Hope you can hear me.
Yes, we can hear you, Achuo.
Okay. So thank you, Dr. Ojong, for the brilliant presentation. Dr. Ojong was actually my classmate in OBGYN residency back in QS some few years ago. So I have 3 questions. The first 2 questions they've answered indirectly, but I'm just going to say them. The first question is on a comprehensive sexuality education. I want to know if there is currently any implementation of CSE in school and out of school by the Family Health Department. I know they asked a question indirectly with regards to that. The second question, Dr. Ojong's last intervention, he talked about the sexual rights approach, which partly answers the question. So my question was, is there any locally developed strategies to some of the barriers to contraceptive uptake? For example, counseling based on stages of change of the client. Because even some women who have access to family planning, they don't take it. So are there any locally developed barriers to that? Thirdly, I know that there is no doubt on the role of family planning in decreasing maternal mortality through unwanted pregnancies. But then a good number of these women who delay pregnancy eventually catch up. They delay pregnancy maybe for educational purposes, career purposes, but when they get to 30 years, you see them start having children fast. So, and that is evident when you look at the cohort fertility. When you look at cohort fertility, you see that the number of children that women actually have throughout their lifetime instead of period fertility it's more or less constant, So won't it be an over expectation to expect that family planning will contribute significantly in attaining a demographic dividend in Cameroon, especially when we know that fertility rates and death rates decrease in European countries to very low levels even before family planning was contraceptives were introduced. Thank you.
Thank you, Ashu. Dr. Ojong, you have the floor.
Okay, thank you, Dr. Ashu, for your questions. As usual, 7 in 1. And as usual, I'll start from the end. Even though I do not know that I would love to know your source by which fertility rates might have decreased in Europe prior to family planning. I hope I got that right. I heard you say that fertility rates decreased prior to family planning. Except the people having infertility, there is no way fertility rates can decrease prior to family planning. I hope you're remembering that we still have natural methods of family planning and modern methods of family planning. And these have been practiced worldwide at different rates for different reasons with different sociocultural realities. Now, I'm one person in my approach to family planning, I'm totally ascribed against coercive family planning. I do not think it is the right of any one program, system, or healthcare provider to dictate to a woman how many children she is supposed to have. Personally, I do not think that's a personal opinion. But I think it is the place of programs and countries and healthcare providers to equip women with information and with services that enable them not only make the healthiest choices for themselves, but make sure that whatever choice they make, they are exposed to having the best possible outcome. I give an example, okay? We know that in obstetrics, grand multiparity is a risk factor. So if you had 5 deliveries before and you're going for the 6th, it's a more at-risk pregnancy than a woman who is in her 2nd pregnancy, for example. And ideally, I will counsel a woman at 5 to say, hey, are you thinking of pressing on the brakes? But I will not consider that she has violated any laws if she chose to went for a seat voluntarily, in full understanding of all the risks she was potentially being exposing herself to, without which it becomes coercive. For me, there is no justification for coercion. It's that now, that's me, because it is the right of a woman to make of her body whatever she wants to do of her body, provided it's a proper decision. And there is no such thing as an improper demand for children. Now, like I'm insisting, that is my approach to sexual and reproductive health. It is to put the woman at the center of the equations and make sure that I equip her with all the information she needs to make her decision. And I understand that sometimes her decisions are contrary to my directives, and it's my place to respect it. So with respect to the demographic dividend in Cameroon, we have a predominantly young population. And the aim is not to absolutely stop procreation, okay, or to stop births, but it is to permit this young population make the best of their youthfulness. Like I said earlier, a pregnant woman may not be economically viable, okay? So we must make sure that if a young person is engaging in pregnancy, it should be because they wanted to. And it should be because they were in a position to offer for that pregnancy or for the incoming baby the best of opportunities, the best of care. That's how I approach it. And I know for a fact that there are fewer single adolescent girls who are willing to get pregnant voluntarily compared to married young adult women. but they do get pregnant. So I would want a single young adolescent girl who doesn't want to get pregnant to make the best of her period of education and work by providing for her family planning services. And if the services are provided to these young adolescents and these young adults who don't want to get pregnant, then we free up resources that should have been spent taking care of pregnancy and newborn, but we also permit them contribute to economic development because they are actively working. That's how I see an economic dividend from a sub-Saharan African viewpoint that doesn't just make us go population control as an economic principle to be achieved at all costs, because we can look at other examples. There's countries who have so controlled their population coercively that they got to a point where you realize that, okay, we are having an extremely aged population, which is sitting on a very small base of young people because they were born at the time when for every 4 babies or 4 fetuses, only one was sure of seeing the light of day. So I wouldn't want to solve one problem by creating another. I'm saying, let us empower people to make reproductive health decisions that match their needs, that match their current desires, and that match their aspirations. And if we can do that successfully, I think we can still achieve a demographic dividend in Cameroon without being coercive. Now, with respect to comprehensive sexuality education and what the Department of Family Health may be doing, it's important to state that the approach must be multi-sectoral and it's multi-sectoral. The Department of Family Health does not control schools. Schools belong to the different ministries of education, whether it's basic, secondary, or higher education, depending on what level of schooling you're referring to. And like I said again earlier, there was an initial attempt, but that was from education, to introduce comprehensive sexuality education at the level of schools, which was met with some resistance. It was really a huge outcry that made books to be pulled out. There is critique we can pose, and I think it's a pro and con situation, okay? Because I don't think public opinion was sufficiently prepared before we initiated that move. I am for comprehensive sexuality education, but I am for parents being part of the decision-making process that introduces their children to sexuality education. I am for the community having a right of say into what kind of information their children are receiving in school and determining whether this education is respectful of their age and respectful of other considerations. You see, you cannot take sexual education from London and apply it in Yaoundé without contextualizing. I'm totally against any attempt to not contextualize reality, however efficient it is as a healthcare intervention. And I do not think that as of the time when we wanted to introduce it, we had prepared public opinion sufficiently, neither had we advocated sufficiently, because sometimes what they reject is not even evil. They are just not sufficiently educated on it. And I think that we tend to underestimate the place of behavioral change communication, the place of information education communication, the place of advocacy within the community, the place of using community heroes, investing in all these community stakeholders, these leaders, to push forward ideas. We have a tendency, there is some sort of scientific arrogance, Ojong Samuel, he's a gynecologist, he's a sexual and reproductive health expert, so what he says must stand. I think we have gone down that road too many times and it isn't working. We could stretch this thing to the failure of the HPV vaccine initiative in Cameroon. It is us not educating and preparing public opinion enough for interventions which are sure to benefit the community. So I think that talk about that, it's a multi-sectoral thing. The Department of Family Health advocates, the Department of Family Health takes part in training teachers, in training adolescent-friendly healthcare providers, such that they are ready to provide these services to the young ones who need it the most. And now, locally developed strategies to barriers, of course. Of course, there's a lot of locally developed strategies, and maybe I'll join the delegate there and also just repeat something Dr. Foma always says. One of our biggest weaknesses is we don't capture sufficiently all the good things we do. We do many good things than we are ready to accept, maybe because we did not declare. Very few people know that in 2013, I started a free family planning unit in Fundo. And for almost a year and a half, 2 years, we offered family planning services for free. And the tendency is each time you say free, people do not uptake. But it was a reverse with us. The moment we went free, there was huge uptake. I can tell you we provided family planning services to 3,000 women in our first year, of which in the previous 5 years, they had not had 300 women receive family planning in Fundo. What was the secret? The first thing is we accepted that PBF, performance-based financing, was already paying us for these services. So we did not need double payment by costing on these women extra, you know. Even if the women did not pay, PBF will pay us for offering these services. So we already had money for it, and we were reinvesting there for what PBF was paying us for family planning service. So we're technically not losing, even though we're saying it was free. That was the first thing. The second thing is we realized that the women who received family planning services for free were more willing to come to patronize our hospital to request for other services. So overall, it improved the user uptake of our health facility. The third thing is, because we're working in a community which, I mean, so culturally, there were huge barriers. We actually ran a free radio spot. It was a 2-weekly radio spot, and it was interactive, where people could call and ask the hottest questions about family planning and reproductive health. The first 2 months were not easy. There were times people would call and insult us, you know, and you just have to be patient. But as time went by, we realized we're breaking the ice. So it was not one thing. It was not just cost only. It was community, it was interacting with them. We had at some point to make use of some chiefs who came on because they were more friendly to family planning, to give their opinion about their wives using family planning. So it was really an integrative strategy. And that was a locally developed idea. But we never got to publish our story. We never got to share our story, which maybe would have influenced other communities. And for having traveled to the far north, to Adamawa over the last few months, I've traveled around Cameroon. You'll be amazed at how many communities are using locally developed strategies to respond to different aspects of social and reproductive health and to health in general. But we're just not capturing it because we're not reporting these stories. So that's what I can say with respect to your last question.
Thank you, Dr. Ojong. And I think this has been a truly engaging session, truly engaging. For some reason, Dr. Ojong's sessions are always on fire. Your questions, your topic, your sessions, it's always really lit. Igwe, I know you have been following this discussion from far. What do you think about today's session?
Well, I'm thrilled with how much insight Dr. Ojong has on this topic. He's a trusted authority when it comes to reproductive health, and he's also a very honest soul. Despite his position in government, that will not make him play to the beats if the things are not correct. And I really like that approach, that sometimes we just have to be honest to say the things the way they are, and without sugarcoating them, and that's just who Ojong is. And I'm happy that he's handling this very important role in the ministry. And I'm sure that his contribution is really going to be remarkable. And we all can agree that the current Minister of Public Health is really open-minded. And I can see that in different aspects of the innovations that are taking place within the healthcare sector. And we are all looking forward to bringing him on the platform. I'm sure Ojong, you play a major role on this, and let's try to see how to keep on also really portraying the positive work that our country is doing, because it is only through really also appreciating the good work that is being done that we can be able to improve. And that's one of the reasons why the town hall is here. It's not just to say the things that are wrong, but to also really, applaud the things that we are doing rightly. And we should also hope that someday will be a model that other countries too can cite. So thank you so much, Dr. Ojong.
Thank you, Elvis, for those remarks. Christelle, do you have some last remarks before we hand it over to the chairman to give us a vote of thanks?
Je vais dire grand merci à Dr. Ojong pour la présentation et les échanges qui étaient vraiment succincts et précis. Et surtout, bon vent dans sa nouvelle position comme point focal national pour la planification familiale. Merci encore et merci à tous d'avoir participé.
Merci beaucoup, Christelle. To all of you who joined us for the first time, we are really glad to have had you. For all of, for all the contributions, we are truly grateful. We know that at times wearing several hats, including that of a researcher and a policymaker, can be at times an uncomfortable place to sit in. I remember back in those days, people used to think that policymakers and researchers are not, they are not friends, but increasingly we've seen people wear both hats. We've seen policymakers and researchers work together for the good of the people. And for those who jumped in with different views, we truly appreciate you. Those who joined in at the level of the region, like our regional delegate, the UNFPA colleague, Dr. Marquis, we are truly grateful for your attendance and for your insights and for your contributions. And we are grateful that we can lean on you today and continue to lean on you tomorrow, either directly as a town hall or through Dr. Ojong. We know how to get you guys. We know that if we try, we don't get in, we'll just say, Dr. Ojong, we need to get these people on board. And we look forward to having some of you join us in future sessions, not just as participants, but as presenters, so that we can get to, put you on the hot seat and hear directly from you in terms of how things are going. Maybe, Dr. Ojong, do you have any last comments before Dr. Foma gives the final vote of thanks?
My last comment will be what I said at the end of my presentation. Women are not dying because of diseases we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. I will leave that as a take-home message. We all think about it and decide whether or not we make the decision that the lives of women and girls newborn in Cameroon are worth saving or not. Thank you.
Thank you, Dr. Ojong. Mr. Chairman, over to you.
Alison, thank you very much. And every day I'm totally thrilled by the number of people who get into the town hall. And OJ, coming here, you always come in with a crowd. At a certain point, I saw almost 60 people log in at each given time. So yeah, it's an honor to have had you like a brother, and you always come in. We're supposed to have a different presenter this week who had an emergency, and you stepped in order to tell us what is happening at the level of reproductive health in Cameroon. So we're very grateful. And the town hall, to everyone who is here, this town hall really does not belong to Alison, to Christelle, or to Elvis, or to any one of us, or to Brian. So it doesn't really belong to us. It belongs to the Cameroonian people. And to anyone who is a lover of healthcare in Cameroon, who is a healthcare professional, who thinks that we can use this platform in order to bring change. And please, if you have any topic which you are an expert or anything which you think we should address, try to reach out to us and we're going to give you a platform. And we know that certain people are unable to say certain sensitive things because of their affiliations at times to their jobs, and also some things are confidential. We always have a parking lot session where you can actually vent out things that you feel are not the right things going on. You can vent so that we can actually know what is happening on the ground. So I think, Alison, I want to thank everyone for coming and for being here. I want to thank the moderators in particular. I don't know how you guys do it. The sacrifice is so enormous that I don't understand how it's done. None of you get any kind of compensation for being here every 2 weeks, so it's wonderful. At least we get to know each other. We've gotten to know a lot of people through this, and we hope in the next 2 weeks we get an interesting topic that we can also sit down and discuss. And I'm always happy having each and every one of you. I see a lot of friends. There is Dr. T, there is Dr. Tambe. I have a lot of friends and classmates who have not spoken anything. There is Wingo, who usually talks a lot too. He's a policy man. So I hope in the parking lot, they'll be able to say their mind. several people here, urologists, radiologists, public health physicians, they have just been quiet. But I hope we're going to the parking lot. We'll have a parking lot session for about 30 minutes to 1 hour, and we can have a chat.
Thank you very much, Doc.